dolgo ali kratko pot. Zdaj lahko poskrbim za svojo družino, ker moje gorivo poskrbi za moj avto. Izboljšani dodatki v gorivih MOL učinkovito zmanjšujejo obloge in tako čistijo motor. Z novo generacijo goriv MOL Evo poskrbite za motor vašega vozila.
Sports participation after myocardial infarction, dead and buried. And the second one will be cardiomyopathies in athletes. Is there a place for competitive sports?
Wonderful. Thank you very much for the kind invitation. If you've got ischemic heart disease, leave the room now because of course there's a very before the music starts. So what's the evidence? You all know that. I'm not going to teach you. Exercise is beneficial for health and it's particularly beneficial in individuals with cardiovascular disease. Okay? And a very good point was made last night in one of the lectures. It's not only how much you exercise, but how much of your time you spend not being sedentary. The more sedentary you are, the more likely you are to suffer from cardiovascular events. Okay? So it's a combination of those two things. However, it is a fact that exercise can trigger cardiac events in individuals with underlying cardiac disease. And it's also a fact that ischemic heart disease accounts for the majority of sudden cardiac deaths in older athletic individuals. And you may think that this is not particularly relevant to you, but look at this study. This is deaths in sports and non-sports related deaths. Ischemic heart disease plays a huge role. And the point here is that we've got an increasing number of individuals who want to participate even at leisure time, so not just 5 or 10K, but marathon, triathlons and ultramarathons. And those people will be coming to you to be checked out or get their certificate. And it's clear, look at those age ranges. They go up to 79 years old, okay? And those people are more likely to have issues with coronary artery disease rather than ion channelopathies or cardiomyopathies. Now, how do we assess an athlete's risk of exercise-related cardiovascular events? Well, ideally what you want to do, you assess the overall cardiovascular risk, okay? Assuming that they may or may not have cardiovascular disease diagnosed already, very important point as well. Then you need to assess the current level of fitness. It's not the same someone who's been exercising all their life compared to a 40-year-old who want to take up exercise now. And then what do they want to do, okay? And then you want to do your necessary evaluation and hopefully provide them with some individualized advice about sport participation. And obviously the risk is a continuum, it's not an absolute yes or no. And depending on your age, cardiovascular risk is intensity of exercise and may come towards the rate. If you have been doing habitual exercise all your life, you're likely to be more towards the green. And obviously there is a huge difference between those two veterans. Chris Hoy, completely different from Homer Simpson, who wants to take up exercise at the age of 40, 45, and he hasn't done any beforehand, and he's got multiple cardiovascular risk factors. Okay? Now, brief case, which makes a very good point. 53-year-old male, he's a very, very, very keen runner, long distance running since the age of 15 years, nationally ranked cross-country and track runner. He's now mountain running, he's ranked third in the world for his age group, okay? Remember, he's in his mid-50s. Now, he's been complaining for the past 2 years that he has some relative reduction of his performance. What does he mean by that? Is that his 10K race has dropped to 34 from 32 minutes. Alright? I don't know how many of you can manage that in the room. And he's been experiencing a bit of shortness of breath. He's got some tightness at the top of his throat, okay? Never had a really chest pain or syndrome. That's his ECG. For all of you who came to our course, you will spot it by now that this is a normal ECG for an athletic individual with significant bradycardia. For the rest of you, come to the course next year. Transthoracic echocardiogram, absolutely normal, no issues whatsoever. Cardiopulmonary exercise test. If someone can fault this cardiopulmonary exercise test, please come and let me know. There are not many people who manage that at the age of 55 years. What would you do next was the question. And that's what we did. You may say, well, he has a lot of significant symptoms. Why are you checking for coronary arteries? But those symptoms seem to be quite significant for him. Alright? And that's a very important point. Now, he demonstrated some proximal and middle AD disease. You're not cardiologists, most of you, but you don't need to be a cardiologist to see that there is indeed significant disease at the very proximal and very tight stenosis at the middle AD. Okay? What do you do with these individuals? Well, aggressive risk factor notification. Irrespective of what his cholesterol level is, it needs to go further down. And statin is a very important drug. And in this particular case, because we had proximal LAD symptoms, we performed PCI of his LAD. What about the exercise recommendation? What would you say to this guy? So it hasn't had an impact, he's got 2 stents now in. We've got this new document from the sports cardiology section of the European Society of Cardiology. Please go and read the document, okay? It's a nice, very simplified document that explains what needs to happen. But essentially, what you need to do as a general principle is, 1, evaluate your athlete, history, symptoms, cardiovascular risk profile, as you will do it for your regular patient, okay? Nothing special for the athlete. History of ischemic heart disease, habitual and intended exercise, clinical evaluation. Please don't look for the very rare things and miss the obvious familial hypercholesterolemia, okay? We need to remember that. And then depending on the history, you may want to do an ECG, an echo, an exercise test, and proceed to further investigations as necessary. Now, as a summary of so this is how you re-stratify. This is exactly what you use for your patients. So you know that's not new, the cardiovascular risk score to detect high-risk individuals. But this is new, and this is the algorithm. I know it looks very complicated. It becomes fairly simple. They divide asymptomatic and symptomatic individuals, and then you have to decide if they've got a history of coronary artery disease, risk of coronary artery disease, a cardiovascular risk score. If it's low, then no problem, they can compete. If the cardiovascular risk score is high, then they suggest exercise tolerance testing. And I know there are doubts about exercise tolerance testing, but in a high cardiovascular risk individual, it is a reasonable request, okay? And then whether it's normal, borderline or pathological, if it's normal, you can go back to exercise. If it's borderline, you will need more investigations, whether you identify disease or not. If those are normal, again, you're eligible. But if they're pathological, or if your exercise test is pathological, or if you've got someone who has symptoms at the end of the day, then you need to visualize the coronary arteries. Whether you do with a CT or a regular coronary angiogram, that will depend on the individual patient, his age, circumstances, and chances of that being true coronary artery disease. And then obviously things will depend whether you identify no disease, and if you do, you need to re-stratify them, and I'll tell you in the next slide how, and then make a decision whether you need to put some restriction or exclude them from competitive sport and advise them on leisure time physical activity. Now, this is how you re-stratify them, okay? That's the list you need to know. Look at the left ventricular function. Is it impaired or not? Look at the exercise capacity with a maximal exercise test. Is there any evidence of induced ischemia? Is there any evidence of arrhythmias that we've just discussed a second ago? And is there any remaining coronary artery disease? If the answer is no to all of them, they're considered low risk, like our patient would be, for example. If the answer is yes, then they're considered high risk and they will require some sort of restriction. The thing that is not addressed is the myocardial scar after a myocardial infarction, which we now know we can see more and more with the cardiac MRI, but that's something for the future. I definitely take it into account. If you had a major infarct and a lot of myocardial scar, then obviously your ejection fraction will be low, so you'll be a high-risk patient, and you will need to go to leisure time physical activity. A couple of key points: listen to the patient history. Do not treat your athlete like the average patient. They've got a lot of results and they're likely to minimize the symptoms. Okay? And athletes with recent events should have complete recovery, 3 months usually post PCI, and complete recovery at least 3 months, I think, after surgical intervention. Okay? They should undergo re-stratification. They should complete a cardiac rehab program that should focus on athletes. Don't get them in a really boring rehab program that you've got for your 90-year-old heart failure patients. They're not going to stay there. They're not going to do that. And maybe that's where the value of potential high-intensity interval training is, to make it more interesting. Aggressive risk factor reduction, and please, please, please take into account your athlete's wishes. And I think that's a record for completing a lecture. If you're interested in sports cardiology, please join European Association of Preventive Cardiology. We've got a nice book. We've got a lot of courses and online material that you can find. Most of them are free. And even if you have to pay, it's a small annual fee. Because at the end of the day, you'll need to have the experience, not necessarily to judge your competitive athlete, but your average 50-year-old who wants to take up exercise, or the 50 or 60-year-old who had his myocardial infarction or heart stent and now wants to go back to regular physical exercise. Thank you very much for your attention. What's the name?
No PhD, they canceled the active breaks, so.
So I was stressing over nothing, guys. Any questions on this particular lecture?
You stressed in your presentation about the point of trying to control the level of cholesterol using statins. What do you think about using PCSK9 inhibitors instead of statins? Let's say the patient prefers the statin. Do you recommend it as a prevention or a way to?
I think that's an excellent question, and I don't know what the right answer is. I've been asking my lipidologists as well, because for me, potentially makes sense to view them as high-risk individuals, because the classic one will be someone who's in his 40s or 50s. He's got 0 cardiovascular risk factors. He's been exercising all his life. His total cholesterol is around 3, and his LDL cholesterol is definitely low too. And you have to treat him with something. I, for the time being, start with statins and try and get them to the maximum dose that they will tolerate with statins. But I do always ask my question whether I should view them in that zone of a high-risk individual, post-myocardial infarction, who would benefit from PCSK9 inhibitors. For the time being, I think the answer for most is no, but in particular cases, it's definitely worth considering.
Congratulations for your presentation, of course. What are your strategies to find any athletes with the outputs of positive exercise testing from CT scan and CT scan percentage yet and on stenosis of 1 or 2 stenosis, but not critical is less than 50%. What's your
I mean,
so you have a double stress test and also significant stenosis.
yes, so it will depend on the case. So if it's clear cut and they're definitely less than 50% and my athlete is not particularly symptomatic, it will depend on why there is.
Asymptomatic.
Yes, so it may be, what my preference would be to go for a very high cardiovascular risk prevention, okay? If I've got any doubt which does happen, occasionally what I'm trying to do is I'm trying to proceed to coronary angiogram to visualize angiographically their arteries and confirm that that's what the lesions are, what the CT coronary angiogram said, so it will depend on the quality of the study that I'm getting. And then it's about aggressive cardiovascular risk profile. In that particular circumstance, well, unless it was a left mainstem lesion, there was other body signs, I wouldn't go ahead with the intervention. It's primarily about aggressive risk factor control.
What about sport restriction? If you perform also coronavirus or they are saying the same things of cities, we have no critical.
So if it's below 50%, even by those rules, it will fall in the low risk.
You make also a bar, so you are sure that there is no scary. What about sport activity?
So it's about aggressive risk stratification, ensure that we establish among that, and then you have to discuss on an individual basis, but I would be more prone to let him rather than restrict him participating in competitive sport. Okay, so next one, cardiomyopathies in athletes. Is there a place for competitive sports? So what we'll try and do a bit slower this time is look at the background of exercise recommendations. Cardiomyopathies in sports focus on HCM and ARBC. We can't obviously discuss all cardiomyopathies. We'll address evidence, knowledge gaps, and current recommendations, and I'll see you how do we go about prescribing exercise or giving recommendations about competitive sport. Now, there has always been concern regarding exercise and cardiomyopathy. This will be an example of an HCM patient where you've got hypertrophy, you've got myocardial disarray, and you've got myocardial fibrosis, okay? And the concern is that in this individual, you may have also supraventricular arrhythmias, you may have myocardial ischemia because they've got microvascular disease as well, and you may have LVOT obstruction, left ventricular outflow tract obstruction. And if on top of that you put the adrenergic surges of exercise, potential dehydration in extreme circumstances, electrolyte imbalances, then the concern has always been that that may result to ventricular fibrillation and unfortunately sudden cardiac death, as it was the case with those two unfortunate individuals. Now, the concern also stems from this study that was published back in 2003 by Domenico Corrado in Italy. And what Domenico said is that if you're an athlete with cardiovascular disease, then you're almost 3 times more likely to experience sudden cardiac arrest or sudden cardiac death compared to non-athletic individuals. Okay? So your overall risk score will be 3-fold. Now, how do we go about assessing athletes? Similar to what we discussed before. Ideally, what you would like to do, if you've got an individual who has some form of cardiomyopathy, you'd like to take a detailed history relating to the condition. The risk of one cardiomyopathy is different from the risk of another. Look at the current level of exercise that they are doing and the intended level of exercise. Then you will perform your necessary evaluation, as we said before, and finally you will provide them with individualized advice regarding the sport participation. But is that actually what we're doing now? Well, these are the recommendations that have been working on in the past 15-20 years or so, okay? And it was the ESC 2005 recommendations as well as the newer AHA-ACC recommendations. They had in 2005 and then they renewed them in 2015. Now, the problem with those recommendations is that, as with most recommendations in cardiomyopathy, they're expert consensus, so the level of evidence is seen. Point number one. They're extrapolating data from the general population. Point three, they're conservative because they try to prevent all sudden cardiac deaths. And point four is that they treat very heterogeneous conditions. It's not only that HCM is different from the RBC, it's also the fact that HCM itself is a very heterogeneous condition in a very homogeneous way. So they definitely do not provide a personalized exercise prescription or personalized recommendation regarding sport participation. Let me make an example here, okay? So we've got 2 individuals in their mid-20s, both asymptomatic, both present to a screening problem, okay? This ECG demonstrates T-wave inversion V1 to V4 and some in the inferior leads. For those of you who came to the ECG course, you diagnosed ARBC by now. This is the cardiac MRI. Look at the right ventricle. It's very dilated, it's very dyskinetic with aneurysms and poor right ventricular function. And he's got arrhythmias and non-sustained ventricular tachycardia during his exercise testing. He's got a diagnosis of ARBC. This young individual has an ECG that demonstrates high voltage and inferolateral deep T-wave inversions, which are very suggestive of hypertrophic cardiomyopathy. His echo and MRI confirmed an apical form of the hypertrophic cardiomyopathy, but he doesn't demonstrate any arrhythmias, and as we said before, he's completely asymptomatic. So he's got the diagnosis of HCM. Now, based on the current recommendations, both of them will not be allowed to do any competitive sports. Maybe by the AHA recommendations, they can play billiards, bowling, curling, golf, and rifle. And I don't know how excited you find those sports, but most people won't. Unfortunately, we've taken cricket now and we've moved it to the modern pace. However, the one good thing about the 2015 American recommendations is that they recognize something that is very basic for the rest of the field of medicine, apart from sports cardiology. The fact that the recommendations do not strictly exclude fully informed athletes from participating in competitive athletics, and there will always be tolerance in the system for some degree of flexibility, individual responsibility, and choice, okay? Exactly what you do in your everyday practice. You inform your patient, you suggest what the best possible procedure is, and then the patient can decide whether they want to have it done or not. Now, let's take as an example hypertrophic cardiomyopathy. What's been going on with hypertrophic cardiomyopathy? We've known about the condition for many, many years, okay? So we're very good at re-stratifying them and identifying the features that suggest a high risk of arrhythmias and sudden cardiac death, based on a systematic evaluation with history, ECG, echo exercise test, and Holter monitoring. We also have established cardiac MRIs gradually being established that myocardial fibrosis is a risk factor for sudden cardiac death in hypertrophic cardiomyopathy. What you will then do is go by the ESC recommendations, go in Google and find that ESC risk calculator. You will put the numbers that you got from your echocardiogram and from your history and investigations, and then you'll come up with a risk score. It will say low, medium, or high probability of sudden cardiac death in the next 5 years. And then what you will do your management can be anything from lifestyle, medical, surgical therapy, and for the high-risk individuals, you may implant an intracardiac defibrillator. But be a bit cautious, because what this clearly states is that this is not for elite or competitive athletes. And it's not for elite or competitive athletes because unfortunately when they did the study, no one thought that exercise may be important in hypertrophic cardiomyopathy patients. So this question was never asked. Not physical activity, forget the competitive sports, not even the physical activity. So the question is, if that applies to the general population, then we must be taking it out from athletic individuals because there is an increased additive risk of exercise on top of hypertrophic cardiomyopathy. And the question is, what is the evidence that supports that risk? Now, a lot of the evidence is circumstantial. It comes from the first study I showed you before about Domenico Corrado, the 3-4 increased risk in athletes with cardiovascular disease. It also comes from this very nice database that Barry Maron in the United States has been maintaining for many, many years, and involving your athlete and his environment, his relatives, his team, his coach, anyone who has an interest, and the athlete wishes for them to be involved. But you do that recognizing the limitation in the evidence that you've got, okay? And that's why you really need to know your stuff before you go and give a recommendation to an athletic individual with HCM. Now this is the table, go and read it, it's a very nice table. What it basically says in 2 words is, if you've got any of the high-risk features, symptomatic athlete with severe phenotype and arrhythmia, then that's an exclusion criterion. But if you've got someone who has mild clinical phenotype, he's asymptomatic, he's got a low ESC risk score, and they put adult age there because obviously adolescent is even more challenging than adulthood in assessing the risk, then it would be reasonable to let some of those athletes continue participating with competitive sport. Another very important change, no restriction for genotype positive, phenotype negative individuals, okay? We don't have strong evidence to suggest that specific genotypes increase the risk of dying from hypertrophic cardiomyopathy. And very important, monitoring and recommendations, regular monitoring every 6 months to a year. Monitor for arrhythmia, that's what my concern is always is. I want to do exercise tests and I want to do regular monitoring when they're training, okay? That's what the key for me, all right? And then don't forget that very basic advice. There needs to be an emergency response plan. They need to educate it about symptoms and they need to look after themselves and avoid be cautious with any supplements that they use or they're given by their coaches. Now, before I finish, ARVC unfortunately is a completely different story. Okay, here we've got issues with your desmosomes, the right ventricular and left ventricular size, and exercise has a detrimental effect. So, if you do a lot of exercise, you'll present at a younger age. You're at high risk of ventricular tachycardia and more rapid progression to heart failure. And consistently, all the studies have shown a 5 to 6-fold increased risk of sudden cardiac death in athletic individuals from ARVC compared to any other condition. Okay? So I'm afraid that for ARVC, sports, competitive sports is not compatible, even for genotype positive, phenotype negative individuals, because again, there are studies, admittedly predominantly in plakophilin 2 mutation carriers, that demonstrate clearly that they can progress to the disease phenotype quicker when they exercise at fairly high level. Regarding DCM and non-compaction, I won't go into it. All I'll say is they follow the HCM paradigm, okay? Asymptomatic, low-risk individuals with a mild phenotype, they may be able to exercise. There are 2 very nice tables in the recommendations, so please go and have a look at them. Word of caution, be certain of your diagnosis. There is a lot of overlap between athletic adaptation and cardiomyopathy. Do not misdiagnose an individual unless you're certain, okay? And the other thing is, please do not use ICDs as a mode for high-risk athletic individuals to be able to continue with exercise. Early patient cardiac disease, what I was going to say is that every patient, forget competitive sport, every patient who comes to your clinic with a condition, they should be able to get some sort of exercise prescription, okay? Every patient should be able to do some physical activity or exercise, and please try and be as specific as you can with it. Moderate exercise is nothing to anyone, okay? And that's a lot of what you hear from cardiologists during consultation. So in conclusion, recommendations for competitive sport cardiomyopathies remain very restrictive for ARVC. They're becoming gradually more liberal for the rest of the cardiomyopathies. An individual with heart disease should be encouraged to participate in regular physical activities, but unfortunately this is hampered by the fear of sudden cardiac death during exercise. And future research will be predominantly registries for competitive athletes and proper exercise programs, and there are a few studies of cardiac rehabilitation in patients with hypertrophic cardiomyopathy for the less athletic individuals. And if you really want to learn about sports cardiology, please have a look at our website where we run an MSc in sports cardiology, and we do discuss all these issues, including exercise prescription in individuals who want to exercise. Thank you very much.
Okay, then we'll leave the discussion. Yeah.
And because I want to jump first. Doctor in Slovenia, I'm expert
for hyperbaric. Thank you very much, Katya. Well, the scientific commission asked me to bring some cases related to prevention of sudden cardiac death in young athletes. So, just for reminding, for a review, is it possible to prevent? Sorry. Is it possible to achieve zero risk when we're talking about this? It's important to remind the risk of sudden death in sports and exercise is higher in younger athletes, and the risk is higher in males than in females. If we see this, this is a U.S. National Registry of sudden cardiac death in athletes. So 56% of all sudden death were cardiovascular in nature, and from the cardiovascular ones, we had most of them due to hypertrophic cardiomyopathy and coronary artery anomalies, myocarditis, and arrhythmogenic RV cardiomyopathy. So typically, if we see European, particularly Italian data and American ones, the difference is basically due to a genetic disease that is much common in northeastern Italy, in the Provincia di Veneto. ARVT, but all the other ones are most common in other parts of the world, like hypertrophic cardiomyopathy. And it's very important to remember that in many occasions there are premonitory symptoms in young athletes who suddenly have died. In those three articles, we see that syncope, dizziness, chest pain, palpitations were relatively common in the previously due to a sudden cardiac death event. So I will try to, hopefully we will have time to see those 4 cases. 2 of chest pain, 1 of chest pain and syncope, 1 of palpitations. The number 1 is a very simple case. This is a male 34-year-old medical doctor. There is a risk factor. And the main complaint is chest pain. He was previously symptomatic. He was a triathlete, very good in the national level when younger, and he continued to compete. And he works at our hospital, and he were admitted with oppressive chest pain with sudden onset 2 hours before the hospital arrived. And he had a family history, very important one. The father was alive but had a myocardial infarction with 35-year-old. The mother is hypertensive, and the uncle died suddenly with 37-year-old, and 2 other uncles underwent cardiac surgery. So very, very young. So it was a very important history. He exercises regularly, and at clinical examination everything is normal, but the cardiac enzymes were altered. So this was his ECG, yeah. And considering a normal echocardiogram and considering symptoms, ECG, laboratory findings, family history, and major risk factor, being a medical doctor, maybe it was not the best, looking retrospectively, maybe it was not the best decision, but he, yeah. Yeah, he underwent coronary angiography. This is the right coronary artery. Yeah, everything clean. This is the left system. Yeah. obstructive coronary disease. The normal ventriculography. So what else could we do? Yeah, cardiac MRI. Interruption of sports practice for 6 months, and he was followed with lab tests for inflammation, echocardiogram, 24-hour monitoring, and exercise testing with 3 months, and with 6 months also everything, but and also cardiac MRI that showed a normal, showing that there was no scar. So he was. All tests were normal. He was released to return to sports practice after 6 months. ECG, sì. Era tipico per miocardite, sì. Quando vedremo retrospettivamente, sì. Sì. Yes, yes. Almost all the leads, but AVR and V1, yeah. But there was no involvement. So let me go ahead. Okay. So this is case number 2. He was a 33-year-old entrepreneur, and the main complaint was chest pain. He was a good triathlete and previously asymptomatic, no risk factor, and he was admitted at our hospital with oppressive chest pain, a very typical chest pain with the irradiation to the left shoulder, left arm with sudden onset, no relief factors, and in his history there was nothing, absolutely nothing. And the diagnosis was chest pain. He underwent chest pain protocol. And he told us he had a thoracic trauma 10 days before during cycling training. And the day before, he performed a chest thorax CT, and it was completely normal. So, was it an acute coronary syndrome, myocarditis, or pain secondary to trauma? So the clinical examination was normal. This was his ECG. Normal, absolutely. Yes, yeah, during symptoms. Yes, but echocardiogram, normal, but the cardiac enzymes after 3 hours were altered, and the chest pain was maintained, irrespective of the ECG that was normal. So, another one. We went to coronary angiography. Okay, so this is the ventriculogram, normal. Can you see here thrombus here in the first third of right coronary artery? Also, you can see here in the posterior descending. Okay. Again, numbers here also. Again. The left system was normal. Left system, normal. Good arteries. Again, the left system. Another view, the spinal view. So, diagnosis was confirmed that it's as an acute coronary syndrome. The possibilities would be coronary dissection due to chest trauma or thrombophilia, maybe. Acute treatment in the hemodynamics lab was a glycoprotein 2B3A inhibitor. No stenting at all, because we wouldn't like to cause a new disease. Yes, true, yes, yeah, aspiration of the thrombus too. And there's no published guidelines for this situation. So there was the possibility of coronary dissection. It was not clear in the first exam. So our decision of our heart team was double antiplatelet therapy, low molecular weight heparin, full dose, relative rest, and to perform a new coronary angiography after 2 weeks. So we did it. Yeah, it was better here. Can you see here a tiny image of a hematome? Yeah. Yeah, here. Again. It was confirmed here. Yeah. It was confirmed by intracoronary ultrasound, a tiny hematoma in the site of coronary dissection. So, a hospital discharged with double antiplatelet therapy, statin, and after 2 more weeks he was released to perform light activities. There was a further ambulatory investigation, mainly for thrombophilia. Yeah, nearly everything normal. This is this has a 40% prevalence, so he was. We have maintained the double antiplatelet therapy, and he was referred to hematology division, who asked us to stop. Yeah, no longer the APT needed. Echocardiogram normal. CPT not bad here after 3 months, and he was released to return to full sports practice after 3 months. This is. Yeah, we know that in many occasions the acute coronary syndrome patients they present with normal ECG in the first few hours. So the sensitivity and we performed after we performed an MRI. There was no scar, and our interpretation is that there was no definitive injury to myocardium. That's why this was the evolution. Very, very uncommon. Yes. Also. So this is case 3, 30-year-old, chest pain and syncope, previously asymptomatic, no risk factor. He was never underwent cardiovascular checkup, and he reports progressive oppressive chest pain with irradiation to left shoulder, so it was typical. And 1 month before, he had a syncope episode, but he did not search for medical advice. Well, here father died with coronary artery disease, and the possible diagnosis was typical chest pain and syncope, radiology to clarify, premature obstructive coronary artery disease, or coronary congenital anomalies, or arrhythmogenic etiology for the syncope. So the ECG didn't show anything, but maybe here was considered normal. This was his exercise testing. Yeah, nothing really expressive, but you have typical chest pain, no ST segment deviation, but he was a new ejective systolic murmur during exercise. So this is his color Doppler echocardiogram. You see here, nearly closing the outflow, the LV outflow tract. I don't know if there is some light. The image is not as good as. Yeah, it's the septum is very hypertrophic, 20 millimeters. Yeah. And he was diagnosed with hypertrophic cardiomyopathy. The treatment was bisoprolol. In fact, we began with 2.5, and every 2 weeks we adjusted to 5 and to 10. He was advised to stop competing. He remained asymptomatic with ordinary activities. Yeah, began light to moderate intensity aerobic exercise, remaining asymptomatic. And cardiac MRI showed late gadolinium enhancement in this region. And Holder 24-hour monitoring further ruled out the possibility for complex arrhythmias he had known until now, at least. And this is our last case. This is simple, but not necessarily related to sudden cardiac death. He was a female soccer player of the best team in Brazil, Fluminense, from Rio. Yeah. And the medical complaint was palpitations. Before being referred to our division, she was asymptomatic until 1 year ago, reported palpitations, and mainly during high-intensity training sessions and games. And she was initially treated with anxiolytics with no relief of the symptoms, obviously. Episodes of palpitations with 3 to 4 minute duration. And nothing here. Yeah. The impression was, this is a very, very common complaint for cardiologists. And the challenge was to make the diagnosis. Would it be anxiety or arrhythmogenic in nature? So lab tests were normal, and this was her ECG, absolutely normal. Yeah. And exercise testing induced palpitations with this maximal heart rate. We can see here, and resting and going. And after 7 minutes, she began to make this and narrow QRS tachycardia with 240 beats per minute. We can see here a detail. Can you see here? Negative QA. See. Atrioventricular nodal ring tachycardia. The proposed treatment was catheter ablation. And in the meantime, while her health insurance was analyzing the request, we began bisoprolol 5 milligrams a day. So this is the catheter ablation. You can see here a very prolonged PR interval, 0.32 seconds. Yeah. This was the conduction by slow pathway. This is the ventricular stimulus here, dissociated from the atrial stimulus here. You can see here, the rapid waves dissociated from the ventricular stimulus. Here was the induction of the nodal tachycardia, as you can see here, to confirm that diagnosis. And this was the application of radio frequency with junction of rhythm. This is his bundle, and this is the site of the application of our radio frequency energy. And this is the end of the procedure with sinus rhythm. This is a very, very recent case. And so the diagnosis was confirmed, atrioventricular nodal reentrant tachycardia. That is, the challenge in this situation is that for 1 year she was being treated as an anxious athlete with anxiolytics. And the treatment catheter ablation, according to the very recent European guidelines, the success rate is 97%. And she was discharged with no medications at all. He's theoretically cured and will be reevaluated. It was 2 weeks ago. She will be reevaluated by the rhythmologist after 4 weeks. Will be with us then and expected to return to training after 6 weeks. Okay, these were the 4 very simple cases, but very interesting that we see all the time. So this is the Brazilian Society of Cardiology and Brazilian Society of Exercise and Sports Medicine updated guidelines for sports and exercise cardiology. It was released in March, in the end of March. We had the pleasure to participate with many other Brazilian specialists. It's available in English, but if you prefer in Portuguese also, that's your choice. And it can be easily obtained. I hope it's correct here. Google Translator said me that, so thank you so much for your attention.
Naj gre za dolgo ali kratko pot. Zdaj lahko poskrbim za svojo družino, ker moje gorivo poskrbi za moj avto. Izboljšani dodatki v gorivih MOL učinkovito zmanjšujejo obloge in tako čistijo motor. Z novo generacijo goriv MOL Evo poskrbite za motor vašega vozila.
Our first speaker today is Michael Turner. He is the medical director of the International Concussion and Head Injury Research Foundation and an honorary senior lecturer at the University College London.
I will take 1 or 2 questions. I'm disappearing off to return to the land of Brexit because I'm no longer going to be European in 4 weeks' time, and I need to find a wife that I can marry so that I can become European again quite quickly. So the EFSMA website will have an advert very shortly. Any Slovenian, Italian, or Greek ladies who are unattached and are prepared to marry for a quick, I'm currently married to a Dutch lady, but actually divorce is pretty quick in Holland, and you can't become Dutch by marrying a Dutch person, which I didn't realize before I think there. To become Dutch, you have to learn to speak Dutch, and you have an exam in Dutch, and you have to learn Dutch history, which you then have another exam in Dutch on Dutch history. So this seemed an awful lot of work to me. So I obviously made a bum steer the first time round, and I'm ready for recycling. Anyway, but there is time, and I'm ready, available. But I will take questions in the meantime if we've got a couple of minutes, and you'll tolerate that. Not on Brexit. Yanis.
My question, as you could probably expect, relates to genetics. Are you looking into that? Because obviously that technology all exists, and it'll be pretty nice to try and identify, not only the fact that there's a genetic component which you clearly indicate, but to actually, I hope you heard me. And the idea is, can we identify those genes so we can actually then implement targeted implementation to try and protect as many as we can?
Yes, so we have a separate biomarker study going on at the moment with Hendrik Zetterberg, who is doing one at UCL. So we're collecting lots of blood. Okay, we're not doing a genome on everybody because there's an expense involved in that. But our cohort of volunteers have volunteered for life. So when people said to me to begin with, we need lots of blood, when you accumulated all the tests they wanted to do, it was 3 liters of blood that I had to take. And I had to explain that we couldn't do that. But we can always go back and get some more. So as long as they're alive, I can go and get some more. So the answer is yes, we're happy to do. We're doing some pretty simple genetic testing at the moment to looking at the high-profile biomarkers that have been identified. But yes, that's what we're looking at. But our cohort is relatively small, and that's the problem. As you pointed out, you need pretty big numbers at the end of the day. But ours is very interesting. These are people who've accumulated literally thousands and thousands of concussions. And what they mean by a concussion is that they basically lost a week or 2 or a month of their life. This is not diagnosed by a doctor. This is people who are essentially, unconscious and working on autopilot. So yes, we're really into it. We're happy if you've got funding to let you, have a go at our genes.
Absolutely. I'll offer to do those samples for you for free.
No problem. Ready to go. We have them all in the deep freeze, and we can get fresh samples if you need blood as well. So, yeah. Ready to go. Here we are. Look, we've got another brave person at the back there. Are you offering to marry me, or are you, or is it only a question about concussion?
Yeah, after this question, Mike will be taking proposals outside the door, and we'll move on to our next
Yes,
speaker.
absolutely.
Firstly, congratulations on a very good presentation. I have a question. How often do you find clinicians assessing cervical spine as well, with, let's say, mild concussion symptoms? And do you think in chronicity the cervical spine could be responsible for some of the signs and symptoms as well? As we know, whiplash-associated disorders produce similar signs and symptoms such as dizziness, headaches, and do you think this is something we should be doing more?
Yes, absolutely. Absolutely essential. Oculovestibular symptoms after concussion and neck problems are a significant cause, and maybe it causes 25, 30, 40% of the symptoms that you get. So if you've got somebody in a post-concussion clinic, you should be assessing their oculovestibular activity and their cervical spine, and then they may need rehab in terms of physio specific to that, and if you're just treating the headache as if it's a concussion, you're missing something. So it's the first line after concussion is stop worrying about the concussion and sort out their neck and their otoliths and the bits and pieces. Yeah, absolutely with you. Anyway, thank you very much indeed.
Thank you, Michael.
Now, the next speaker, let me introduce Amit Mistry. Amit Mistry is a psychiatrist currently working as a specialist in the eating disorder cells. Please, Amit. Amit will speak about United Kingdom perspective in sport and exercise psychiatry.
Hi guys, Dobar Dan, good morning. My name's Amit, so I'm a psychiatrist from the UK. It gives me great pleasure to be representing the Royal College of Psychiatrists Sport and Exercise Group. So we're a specialist group in the UK. We've only been around for about 2 to 3 years. Dr. Yanis yesterday spoke a little bit about mental health and the increase in awareness of that within elite sport. So what I intend to do in the next 40 minutes or so is just give a bit of context of sports psychiatry, how a psychiatrist get involved in the elite sport level, what's the history of that, and what are some of the global themes that are occurring at the moment, and also some examples of what we're doing within the UK. The second part of the talk will just cover some contentious themes, so we'll kind of pick 3 issues where physical health, mental health overlap, and is quite contentious at the moment. And then I'll just give you some examples of what we tend to do in the next year or so as a group. So when we think of sports medicine, like what is sports medicine? We talk about it being a specialist area within elite sport, thinking about medical problems related to sport. Now, if we look at that in further detail, we think about the rationale of that, and also think about the key elements of strategy. We know that the rationale is that injuries are common and they're important within elite sport. And if we're going to manage that, we want to prevent it in the first place. We want to have a good screening tool. We want to detect it early. You want to have timely access to an expert in that area. And then you want to prevent it from happening again. Now, we believe as psychiatrists that we can do this within sport as well. We don't have high-level evidence, so we're not talking level 1. We're talking about level 3, level 4 evidence. But as you'll see, recently with the International Olympic Commission's work a few months ago, there is increasing awareness of some of the challenges that you see in elite sport regarding to symptoms and severe mental illness in that area. So we know that, especially through media stories, you can be an athlete and you can be successful with a primary psychiatric disorder. We also know that you can use sport as a way to manage your mental health. So if you think about ADHD and this excessive energy and using that as an outlet towards your sport, that we know works as well. However, to understand the sports psychiatric culture, so understand the culture of sport, we also know that there are certain aspects of sport that can exacerbate a mental illness or even trigger a mental illness. And Dan Beagle, so from the US, in 1992, did a kind of pinnacle paper. It was called The Overview of Sports Psychiatry, and he was the first who really gave the concept and the framework of sports psychiatry. And he also spoke a lot of the skepticism for the role of psychiatry in sport. But over time, we've seen the evidence base grow, and in 1993, 1994, the ISSP, the International Society of Sports Psychiatry in the US, was set up. And these are clinicians and sports psychiatrists who are very interested in elite sport mental health. I'm not going to go through all these kind of books, but it's just to demonstrate that over time, we are creating a greater evidence base for mental health challenges within elite sport. So the difficulty is, when we think of prevalence of mental illness in elite sport, it's very difficult to capture the data from elite athletes. A lot of the things that we have to do is based on clinical opinion, based on the general population, and that in itself is a challenge. And a lot of the instruments that have been used in elite athletes are not validated tools in athletes. So again, that's a challenge as well. We think about cross-cultural differences. If we're doing lots of studies in America or Australia, can we apply that to other athletes in different countries as well? A major limitation. And also, a lot of the studies that we have are self-report. So the retrospective, and we're asking the athletes about symptoms as well. If you're an athlete with potential eating disorder and you're being asked a screening tool, there's a high risk of you minimising your symptoms, fear of deselection, and fear of sanctions being put in place because of an eating disorder. And we know that the gold standard for diagnosing an eating disorder in elite athletes is a one-to-one interaction with a clinician who can assess that. The prevalence rates of mental distress is variable, so some talk about 5%, some 35%. A lot of the studies have been done in Australia, and we've recently done some studies with the English Institute of Sport, which I'm not allowed to talk about at the moment, but we've had some interesting findings in the next year or so do watch this space. And something that's well established is the role of eating disorders for females in elite sport. So think about factors. So we know that the age, general psychiatric illness within the general population tends to peak in late adolescence, early 20s, and that kind of coincides with elite performance and when you're kind of hitting your peak as well. When we think about generic factors and also sport-specific factors, we know that people who have musculoskeletal injuries, who have multiple surgeries, who have performance concerns, and maladaptive perfectionism, we know that they're a high risk of mental illness as well. Think about career dissatisfaction, so if you've been deselected, if you're injured, if you're forced to retire, we know these are particularly vulnerable periods for athletes as well. We know the role of substance misuse, just like the general population, and how that can affect mental health. What's interesting at the moment is thinking about Paralympians. So there's not been much work in that compared to able-bodied athletes, but we know that they have particular challenges compared to able-bodied athletes. So thinking about injury status, use of medications for pain, these types of areas. So this is something that's expanding over time as well, thinking about how do we support them best with their challenges. So I mentioned the IOC, so International Olympic Commission. So in June of this year, 2 editions of the BJSM were dedicated to mental health symptoms and illness in sport. If you haven't read it, I'd highly recommend it. It was 14 papers, so narrative reviews, systematic reviews, meta-analysis, looking at some of the mental illnesses that we see in elite sport. And sometimes it's very difficult to differentiate between, well, what is functional for the athlete, so thinking about performance anxiety, and what is a disorder, so what's generalized anxiety as opposed to performance anxiety. What is an eating disorder in a sport? Because thinking about the function of an athlete, it's a very fine line between what we'd call disordered and what is athletic eating. So I'd really recommend reading these papers if you haven't done so already. So all psychiatrists work in the biopsychosocial principle. So in terms of bio, think about medical aspects, potentially could be medication, psychosocial being psychology, what's the social support structure. If we've tried these things, if we've tried psychosocial, then we have to use medication. That's the kind of next line that we'd use. The difficulty that you've got in psychiatry is if you're going to prescribe certain medication for an athlete, you do not want to cause them any negative impact on their performance. So for example, think about weight gain, sedation, prolonged QTC, bradycardia, all these kind of cardiac side effects we wish to avoid. So any psychiatrist who prescribes medication for an athlete needs to be aware of this. Secondly, so if somebody is depressed, so if they're anhedonic, have lack of energy, low mood, are we prescribing medication that's going to help them with their depression to get them back into the sport? And also think about safety risks. So a good example would be a medication like lithium. So lithium is is prescribed in bipolar mania, and we know that it can reduce suicidality in the long term. However, it has to be within a tight therapeutic window, so it has to be a set level in the blood. And if somebody is dehydrated or sweating excessively, that may impact the levels as well. So again, these are other factors that we have to think about. The final thing I want to mention, which again is very contentious given the environment at the moment, is the non-therapeutic performance enhancement. So thinking of therapeutic use exemptions. So within the UK, so around 2014, there was a huge spike in TUEs, so treatment use exemptions. And our lead of our college, so Prof. Alan Curry, he led this review, and what they did with the UKAD, so the UK anti-doping, was tighten up the process before a TUE gets granted. So thinking about methylphenidate for ADHD, there has to go through a more rigorous process before a TUE gets granted. So again, a very controversial issue within sports medicine. I guess some of the things when you think about before a TUE is granted is if this person does not have this medication, there's going to be a detriment to their mental health. They should not be using it because they're already taking it and they're trying to cover themselves for taking that medication. And also it should not be there for them to have a performance enhancement, so it shouldn't give them an unfair advantage to take that medication. So just a little about the UK journey. So in 2015 we had the Mental Health Charter for Sport and Recreation, and that does two things. So to promote good mental health within the national sporting organisations, and I was thinking about how do we promote physical activity for the general population as well. And I think we have about 320 organisations that have signed up to this. Another good progress for us in terms of combining physical and mental health support for elite athletes was two of our colleagues within our sport and exercise group. So Alan Curry and Alan Johnson were two psychiatrists who got elected onto the high performance pathways for world-class athletes. So thinking about podium potential athletes and optimising their mental health. So a step in the right direction, thinking about psychiatry and psychology, working together to optimise mental health for our athletes. And then the group that I'm part of, so we set up 3 years ago, and it's with the vision of Alan Curry. We were seeing the kind of bigger picture globally in terms of the needs of elite athletes, and now we have a small network within the UK. We're still the smallest group within our college, but we are growing. We're the fastest growing group within our college. There's lots of kind of positive direction for this group within the college. I'll just touch on this very briefly. So the second aspect of being in sport and exercise psychiatry is promoting evidence-based, safe exercise interventions for patients that we look after, so with severe mental illness. There's been researchers like Philippe Schuck, Brendan Stubbs, Simon Rosenbaum, David Van Camfort, lots of great researchers that have shown the robust evidence base for exercise and its use in severe mental illness. So something that we do as part of our special interest group as well. If you're interested in learning about exercise psychiatry and sports psychiatry, we recently did 2 CPDs, so continuing professional development modules, and you can get that from our college website. So that's something that we got involved with as well. I'm not going to talk too much about this. You can attend Prof. James's talk later on moving medicine. These are some of the great examples of the initiatives that we have in the community looking to raise the profile of physical activity for people with severe mental illness or just with physical health needs. So some great initiatives there. So the second part of the talk, so we're just going to move on to some of the topical issues within sports mental health at the moment. The first one we'll be looking at is eating disorders. Then we'll think about overtraining syndrome, and then thinking about persistent post-concussion symptoms in sport as well. If we think about eating disorders as a group, what kinds of sports do we think have a higher risk of eating disorders? If we just shout it out, does anybody have a category in mind? Perfect, yeah, so athletics, so we kind of group that endurance. We had gymnastics, so aesthetic sports. Any other types of sports? Yep, so like weight categories, so that's really good. We know team weigh-ins, having to reach a certain weight as well can trigger disordered eating behaviours. Perfect. So we've got most of them. The only other one is anti-gravity sports as well. So that can also trigger the risk of eating disorders. So this was a great study that was done by Sundgaard Borgen and Tortsveit in 2004. The limitation in the literature in the past was that they always struggled to get a high sample number and also to get men into the study as well. And what was nice about this study is they did two things. So they used a validated screening tool, but also they had a one-to-one session with a clinician as well, because I was talking about the risk of athletes minimising their distress when it comes to an eating disorder. And this was the first study that really kind of stratified the different types of sports where you're at higher risk of an eating disorder. And what's interesting from this, if you look at the men, so if you're a male athlete, 8% are at risk of an eating disorder, and if you compare it to the general population, it's about 0.5%. So there's a 16-fold increase in risk in terms of having disordered eating if you're a male in elite sport. And I borrowed this slide from Alan Curry because I think it's a great slide that just shows you the continuum and where an athlete fits inside this, because we can argue what is normal eating anyway, but if you think about an athlete's occupation, they're very rigid, disciplined to their sport, you could argue that the way they train is actually disordered in itself compared to the general population. But we know that athletes who can stop as soon as they're out of training, no longer in competition, we know that if they stop that, we know that that's not a dysfunction. We know that those who have dysfunctional behaviours, so thinking about vomiting, using laxatives, restrictive eating, these types of habits, that increases your risk to then go all the way along the spectrum to a full-blown eating disorder. And has everybody come across REDS, so relative energy deficiency in sport? Have people come across that term? Yeah, so a few nods of the head. Yeah, so this again, the reason I brought this up is that it's quite contentious as well in terms of, if you think of REDS in itself, is it a diagnosis in itself? And we'd argue that it's not, in that we know that it's describing energy balance, so how much energy is coming in and how much energy is going out. And sometimes people just get that wrong by accident, and that in itself is not disordered. But sometimes people may restrict how much calories are coming in, and that can result in REDS. But also they can have excessive energy, so they're over-exercising. What concerns as a sports psychiatrist is sometimes the underlying anorexic cognitions or the reason why this is happening is not explored. And when I was working in an eating disorder clinic, I'd often have people coming in saying, oh, I've got REDS, I've been told I've got REDS, but actually the underlying pathology was never kind of managed or explored. So I think it's really important that if somebody is presenting in this situation that we work out is anything else going on as well. And the reason why that is so important is that out of all the psychiatric diagnoses, eating disorders is the worst in terms of physical health complications. 50% will die from a physical health complication from the eating disorder, and 50% die by suicide. And what we know is that if we don't address the weight loss early on, and if people lose their menstruation, and we don't get that back for them, year on year, they will lose 1 to 2% of their bone mineral density. So it's really important that if we suspect an eating disorder, that we treat them quickly and early, because we know that they have a better prognosis, both from their physical health and their mental health point of view. And also by nature of being an athlete, we know that athletes tend to have a thicker bone mineral density. So if you have an athlete who's osteopenic or osteoporotic, then that should be given red flags already, because they shouldn't be having thinner bones than the general population. So something to be mindful of if you see these people in clinic. So the second thing I'd like to come on to is overtraining syndrome. And we know that people with REDS, so relative energy deficiency in sport, have a higher risk of also having overtraining syndrome. In the UK, we prefer the term unexplained underperformance syndrome because it puts less emphasis on the training aspects, even though it's not just down to overtraining. You guys will know more about this pathway than myself, but all we know is that if you're overtraining and overdoing that, you're at risk of having overtraining syndrome. Classically, the view was always it was just down to that mismatch in exercising. We now know that there's other factors that are linked to unexplained underperformance syndrome in sport. So thinking about poor sleep, if you have prolonged REDS, so we're not just talking about 1 or 2 days, but we know that if it's over 8 weeks, over 12 weeks, that increases your risk of underperforming, and also having concurrent psychosocial stresses as well. So just thinking about what defines overtraining syndrome and some of the symptoms that you tend to experience. And I kind of put these up here. But what's interesting, the ones that are in red are also a lot of the symptoms that we see in major depressive disorder as well. So thinking about the core symptoms of depression. So the core symptoms of depression, so low mood, anhedonia, lack of energy. These are the core symptoms, and we have that in overtraining syndrome as well. If somebody has these and they're depressed, do we call that depression or do we call that overtraining syndrome? So again, very difficult sometimes to work out what is a physical health disorder and what's a mental health disorder. So there is an overlap in that as well. And I think yesterday we were talking about neuropsychiatry and some of the latest developments. And what we know is that depressed patients, a certain subgroup, have higher rates of CRP, interleukin-6, tumor necrosis factor. They tend to be a different profile compared to the typical types of depression that we see. And when we think of overtraining syndrome and being in prolonged reds, we also know they have raised inflammatory components as well. And there has been a query as to whether we can use certain medications like bupropion, which we know is on the WADA monitoring list, in that could this help people who are no longer exercising out underperforming. So it is really interesting where this area is going in terms of the immunopsychiatry with this, in terms of is there overlaps between the physical and the mental health again. So the final thing I'm going to touch on, and I'm going to keep it quite brief because I've already heard Prof. Turner talk about it extensively, is concussion syndrome. So classically, psychiatrists have no need to be involved with concussion because we know it's common. We know that up to 30 days, 3 months, it can happen. And when we think of neuropsychiatric syndromes, we're talking about changes in emotions, behaviour, memory. And if you look at the SCAT-5, so the sport concussion assessment tools, a lot of the symptoms within that are neuropsychiatric. A lot of them are related to depression and anxiety. So if we know these happen and they subside on their own accord, great. Psychiatry does not need to get involved. But what we do know is that if it goes past 3 months and it's having an impact on somebody's function on a daily basis, then maybe we do have to think about medication. The other thing that's contentious at the moment is thinking about repeated traumatic brain injuries and how that affects risk when it comes to psychiatric symptoms. So there has been some studies that have looked at depression, and people who have had 5 to 9 concussions or more report greater rates of depression, and also when it comes to cognition as well, so thinking about memory and thinking about attention as well. In terms of other psychiatric comorbidities, so thinking about PTSD, ADHD, learning disabilities, the evidence base is really poor, so there isn't much in this area, so I don't think anybody can conclusively say that based on a head injury you're at high risk of certain types of psychiatric conditions. I've just put this up because I think it's a great diagram in terms of thinking about repeated mild TBI. We spoke, Prof. Turner spoke earlier about dementia pugilistica, and thinking about these repeated injuries to the brain and how that affects neurofunction and cognition. And I think it's very difficult within psychiatry to talk about clinical symptoms that are compatible with CTE. As we know, CTE is not an established diagnosis from a clinical perspective, it's only through pathology. And there's such an overlap between having a normal injury anyway, compared to what we then call CTE. So it's very hard to make that diagnosis when you see somebody early on. So just to finish up on management options, so again, going back to that model of biopsychosocial and neuropsychiatric symptoms. So firstly, we need to be giving patients good psychoeducation on a concussion and explain that most people do recover early on. We don't want to scare them about the future. We were talking about risk before, when it's such a contested area already. We know that there's the Buffalo concussion treadmill test, so that's getting people exercising slowly, and we know that once they're back to their baseline exercise tolerance, that might be a marker in itself that they're getting better for the concussion. And when it comes to psychiatric interventions, again, the evidence base is very limited in this area. So a lot of guidance in this area is based on clinical opinion and expertise that is based on the general population. It's not on level 1 evidence that was discussed earlier today. So I've put this up there just as a guidance. This isn't definitive, but these are just some of the medications we may have to offer if we're thinking about somebody who is depressed, someone who may be anxious or who is psychotic or is having memory problems. Again, this is flexible and this is based on the patient in front of you, so it's on a case-by-case basis. So hopefully today I've given you an insight into what psychiatrists offer sport and how we are still a kind of growing specialty within our own right. Some examples of what's happening on the global scale, but also what's happening in the UK, some of the initiatives that we've got going on. Hopefully I've given you some examples of grey areas within elite sport mental health and how there's still a lot of work that needs to be done before we can give definitive guidance in this area. And hopefully I've demonstrated the importance of MDT working, so thinking about certain conditions that would benefit from biopsychosocial intervention and also support from the other members of the MDT. Personally, I just want to thank Professor Alan Curry, who's our sepsis chair, who's been very supportive of me and my kind of learning through sports psychiatry. And finally, I just want to let you know about a project that we're doing at the moment, so case studies in sports psychiatry. Myself, Alan Curry, and a colleague called Tom McCabe, we're going to release a book with Cambridge University Press next year, and that's going to be 10 cases, so the 10 most popular sports globally, and how psychiatric conditions may present in those sports, and how to manage them, and then 5 MCQs, so multiple choice questions and learning from that. Our USP, so what's unique about this book, is we've managed to collaborate with 10 athletes as well. So 10 athletes will be contributing to this text as well to give us their perspective of this area. And we want this to be out next year, mid-2020, with the Olympics. So thank you for inviting me today. Please grab me afterwards if you want to have a chat. I'm more than happy to discuss this in greater detail. Thank you very much.
We do have a little time for questions, if anyone has any. Giannis.
Thank you very much for that. The prevalence of doping is unknown, maybe as much as 50%, if we can use that. Living a life of deception, you can't tell your family, you can't tell your friends, you can't tell your fellow athletes. And there must be a huge...
So the book that I've alluded to is a case studies in sports psychiatry. We've got a cyclist called Luke Rowe, and he's been very open to demonstrate your availability and the challenges of that. In terms of the psychiatric stresses of that, I don't think I could comment on that. This isn't a plug to buy the book, but he will talk about it in that.
Okay, thank you.
Ahmed, appreciate your presentation.
Now I have the pleasure to introduce you my co-chairman, Dr. William Oliver Roberts. Dr. Roberts is a professor and director of Faculties Affairs in the Department of Family Medicine and Community Health at the University of Minnesota Medical School. Dr. Roberts will present about exertional head stroke, a risk of participation in unexpected warm condition.
Well, thank you. My presentation is on exertional heat stroke, and I wanted to thank the program committee for inviting me to speak today, and it's always been on my bucket list to follow Michael Turner on a program, but I realize you have to be careful what you ask for because I'm nowhere near as entertaining as he is, so you'll have to put up with me. So what's the brain doing in heat stroke, or why is this in the Brain Matters section? Well, when you think about the definition of heat stroke, it's brain or CNS changes in the presence of hyperthermia. So high body temperature alone doesn't make the diagnosis. It's the CNS changes that accompany the high temperature that makes the diagnosis of heat stroke. And I would suggest that if you looked at a person with heat stroke, you may have difficulty telling if he's had a concussion, or you may have difficulty telling if he's acutely psychotic, because the symptoms are shared. So it is an appropriate place on the program for heat stroke. And what I'm going to address today is the risk of participation in unexpected warm conditions. So what I'll be showing you is why is an unexpected environment that's very hot a risk for heat stroke. And we'll talk a little bit about heat stroke risk factors, define the unexpected heat and what that means, look at some data that I have on unexpectedly hot events, and then just briefly talk about heat stroke reduction strategies and field care. This is the headline in Minneapolis a week after the opening of pheasant season in South Dakota. It was an incredibly hot day for October, and 100 hunting dogs died. They died because they ran ran with abandon. They just were doing what they do, and what they like to do is hunt. And so they were running hard in hot conditions. They don't lose heat well because of the fur. They couldn't pant enough to lose heat, and they died. And so the owners didn't intend to kill them. They just died from heat stroke. And football players are the same. They're enthusiastic. They're like hunting dogs. They're doing what they love to do for a coach who's going to pick them for the team, and they will play with abandon if we let them in really hot conditions. And you know, these deaths have caused a lot of controversy in the U.S. in youth football, and somebody decided that it was time to sue a coach. So he was charged with reckless homicide, which means that a reasonable man should have realized something like this could have occurred. In 2008, we knew that if you practiced hard in hot conditions with football equipment on, that you could die. Now, the coach was acquitted, but I've kind of changed this charge to a reasonable man should realize this can occur. And we do know that heat stroke can occur in hot conditions. So additional heat stroke is really above temperatures that any IRB is going to let us study. If I go to my IRB at the University of Minnesota and say I want to bring people up to 110 degrees Fahrenheit or 40 degrees centigrade rectal temperature and see what happens to them, not going to happen. But where we learn about heat stroke is in what I call the heat injury care labs of road racing, football practices, military training facilities, and soccer tournaments. And what I'm going to do is talk about some of the data that I've accumulated over the years regarding heat and heat injury. So the greatest risk of heat injury is being not acclimatized in hot, humid conditions, doing high intensity or long duration work, especially wearing insulating equipment. But I want to emphasize that even though this is the highest risk, you can still get heat stroke in relatively cool conditions, and I'll try to demonstrate that with some of the slides. So just a little basics of thermodynamics. Heat exchange, both the gain and loss, occurs through conduction, convection, evaporation, and radiation. And you probably all remember this from chemistry and physics. Conduction is direct touch. Convection is flow, either fluid or air, past a body. Evaporation is the evaporation of sweat away from the body. And radiation is what we gain from the sun or reflected back from the road. So a square black block placed 4 feet above the ground is going to lose or gain heat by convection, conduction, radiation. You can add sweating by tossing some fluid on the block. The difference between that block and a human is that a human is exercising. To do that exercise work is generating heat from muscle work, and about 75% of that heat is extra heat that just needs to be removed from the system. So the temperature, the conditions that allow heat change can affect how high the body temperature goes. In addition to the environmental factors and the thermodynamic heat exchange, there are non-thermal factors that affect heat stroke. One is the body blood volume and total body water, which affects the transfer of heat. And we think of the vascular system as transporting oxygen to the muscle and other organs, but it also is the heat transfer system from the deep organs to the exterior. It also allows sweating if the body water is at the right levels. Heat acclimatization occurs with prior exposure, and we'll spend some time talking about that, how physically fit you are going into the exercise bout in the heat will make a difference. But other things like recent viral illness, medications that you're taking, supplements, and possibly genetics associated with malignant hyperthermia may also affect that heat balance. And so those also have to be taken into account when you're making your decisions about exercising in the heat. So a kind of a box representation of what the heat balance equation includes, which is the heat produced minus the heat removed, giving you a post-exercise temperature. But all the factors on the right side of the slide, from how you slept and were you in air conditioning or have you been ill, to are you acclimatized, is your sweating rate adequate, can you transport the heat to the outside, all contribute to that final exercise body temperature. There's also individual heat resistance. So some people are heat tolerant, some people are temporarily heat intolerant, and some people are always heat intolerant. So this show, is from the 1984 Olympics. This was the first time that women had been allowed to run the marathon distance in the Olympics, and I'd been involved with marathon medicine for a few years, and I was keenly interested in this. And during this race, Gabriel Anderson-Shees developed heat stroke, and it's videoed, and you can see it at this link on YouTube, the actual course that she took. And she's always heat intolerant. She grew up in Switzerland, at the time was living in Idaho near Sun Valley and training there. And the announcer said she will never run again, as fact. But to tell what's happened to her in later years, and I got to know her through this, is that she came back and won the Twin Cities Marathon twice, outright as an open runner, and then as a masters runner, won the masters division and the open division. So she was still a good runner. She just didn't do well in the heat. She also came back and skied the American Birkebeiner, which is a 55K Nordic ski race, and won that also. Now, Joan Benoit, who's one of my heroes, won that gold medal, and she's pretty heat tolerant. She does well in the heat most of the time. So how you are individually makes a difference, and that may be genetic, it may be just how you grow up, it may be how acclimated you are. There are also the major risk factors for heat stroke. And if you look at the industrial literature, the two biggest factors are a previous history of heat stroke and not acclimatized to the current conditions. So who's going to get heat stroke? Firefighters in hot conditions wearing their equipment, military personnel, and if they've had previous heat stroke, they're at higher risk. So what's unexpected heat? I would define it as a wet bulb globe temperature that's higher than the usual conditions for that time of the year or that season. It's a time when local participants aren't acclimatized to the conditions. So on Sunday is the Twin Cities Marathon, and we'll talk a lot about that in the data that I have. But if it's a hot day on the first weekend in October, our participants locally, which is probably 80 or 90% of our participants, aren't acclimated to the conditions any longer because we were so far past the solstice, and we've gone through a period of loss of acclimatization. The other part that I think is a big factor is that competitive people don't self-regulate their pace or intensity to match the conditions. When you say on your mark, get set, go, we go, usually as hard as we can for as long as we can, and that adds to the risk. So here's data from Twin Cities Marathon. This is based per 100,000 runners. For each cardiac death, we have 3 cardiac arrests, 4 hyponatremias, 13 heat strokes, and 2,400 exercise-associated collapse or postural hypotension type of problems. So our main problem is trying to distinguish these severe problems from the everyday problem that we see at the marathon. So when you look at that heat stroke number of 13 per 100,000, most of them come from this red circle and this yellow circle. So those 3 races contribute most of the heat strokes to our database. So you have to take that into account when you look at the data. Also, in the green circles, in this -1 to about 10 degrees centigrade range at the start, we still have a heat stroke now and then. So we have to be cognizant that you can still get heat stroke even when that conditions are ideal, and some other factor has contributed to that heat stroke. So Keating looked at heat stroke mortality associated with the latitude at which you live. So what he found is that heat stroke occurs more frequently at a lower temperature in a lower temperature range as you increase the latitude away from the equator, either to the north or south. And what this implies, along with the data, that as summer temperatures rise, that temperature at which heat stroke occurs goes up also, is that living in an area gives you some acclimatization to that area. So that's very important for competitors in a local area. I'm not sure that it's the same acclimatization they had when I was a kid. We had no air conditioning, there was no air conditioning in our cars. Work wasn't usually air conditioned, so we were living in the conditions more than kids and athletes do now. So athletes adapt to heat with two basic functions: physiological acclimatization and behavioral adaptation. What's different about athletes is athletes ignore the normal responses to heat and continue anyway, which is why it's so important that we have some administrative guidelines for heat. You know, when I feel like I'm getting hot, I pull out the lawn chair, crack a beer, and sit down. That's why I was never an elite athlete. I couldn't push past this in hot conditions, and so some people can. Gabriel Anderson-Sheets was running in the first Olympic marathon. She tells me that she was conscious of what was happening the whole time on this course, but she wanted to finish it because it was the first women's Olympic race, and she didn't want to be known as the person who didn't finish it. However, if you look at Paula Radcliffe, and this is from, I think it's the Athens Olympics, she didn't feel so good in the heat, and sat down on the curb because she knew that a month or two later was a big paycheck if she won the next competitive race, and the Olympic gold medal was out of reach, so it makes sense for some people to step out, and I think it takes a lot of cognitive thinking to understand that what you do. So physiologic adaptation to heat is that process that occurs in the body with repeated exposure to heat. And that hot environment will, over time, decrease your heart rate, increase your plasma volume. It increases the plasma volume by about 1 liter, which is very similar to what happens in pregnant women. Their volume goes up by about 1 liter. I think for pregnant women, so they can lose a little more blood when they deliver. I think for athletes, it's so they can sweat more and cool better in hot conditions. The sweating volume goes up. The distribution of sweat around the skin gets greater. So if you're looking at someone who's not acclimatized to heat exercising, you'll see a lot of sweat in the trunk, but not out on the arms. And you look at people who are acclimatized to heat exercising in the same conditions, you'll see the sweat on the arms and legs too. So they've moved that circulation to the outside where it's going to do the most good. You also get earlier sweating, and you decrease the amount of sodium excreted in the sweat to help preserve sodium. When you're trying to become acclimated, you get some protection as little as 3 to 5 days, so some reason to get to the competitive site early. The most onset is in about 2 weeks, but the best improvement is 8 to 12 weeks. So when you see the Olympics coming up in sites that are known to be hot, people will move to conditions that are similar for about 3 months before the races to try to get acclimatized to those conditions. And not every athlete can do that. The athletes coming in from Scandinavia and Canada to run the Twin Cities Marathon on Sunday aren't going to be in hot conditions prior to the race. So the USA Cup is a youth soccer tournament in the Minneapolis-St. Paul area. It's the 4th largest in the world behind the Norway Cup, the Dana Cup, and the Goethe Cup. And it is scheduled in what's traditionally the hottest week of the year in Minneapolis, which makes absolutely no sense to me, but that's what they do. And you can see we had a really hot year, and in that hot year, before we made some accommodations, we were losing people to heat at a pretty high rate. After the 5th of July, in that week, we instituted free substitution, water breaks, mandatory water breaks, and we tried to send people off the site to try to improve things, and the rates went down. So that helped. When you have unexpected heat, several things happen. First, the finish times are slower. And you can see in the graph here the Olympic records compared to the world records. And at Olympic sites, which have tended to be hot, there's a big difference in the record times. The other things that happen, especially in road racing, is people don't start. So I think they might be the smart ones, but they don't start. On-course dropouts or did not finishes increase, and on-course medical encounters increase, and finish line medical encounters increase. Hospitalizations increase, and both heat stroke and exercise-associated hyponatremia increase. So that's what happens when you're not acclimatized and you still go out and run. When you look at performance effects, Eli and a group of us looked at what happens as the wet bulb globe temperature ranges from 5 to 25 degrees centigrade for men and women, and across different ability levels. So elite, sub-elite, and citizen, and the times predictably reduce as the temperature goes, and it affects the slower runners even more than the faster runners. So back to this. This graph represents what I call unsuccessful starters. So it takes into account people who start the race, don't finish, plus the number of people who are seen in our medical tent, divided by the number of finishers per 1,000. And what happens in Twin Cities is that as the temperature goes up, less people start. So you start to see this curve develop. And in the underlying numbers are the number of heat strokes per 10,000 finishers that we see in the conditions which are marked green, yellow, and red. So looking at some other marathons, Boston Marathon was the third Monday in April, which happens to be Patriots' Day. It's 100 days from the summer solstice. At this time, they were starting at noon. And the average high is 60 degrees and average low is 40 degrees, which are the same temperatures as Twin Cities Marathon, which is run in similar relation to the summer solstice, but in the fall. So from Jones' work, increased temps result in increased incidence of all injuries and increased incidence of do not finish. Here's the curve from that time in the 80s and 90s when Bruce was collecting this data. And when he sort of stepped away from this, he gave me the database and said, do what you can with it. And I haven't published it, and he didn't want to publish it, but this is the curve. As you see the wet bulb globe temperature increasing, you see the number of encounters per 1,000 finishers start to rise also. If you take the Twin Cities Marathon data, which starts at 8 a.m. in the coolest part of the day, and shift it down by about 30 on all these numbers, you see that it's the same, basically the same curve for Twin Cities Marathon. So this is when the Boston Marathon was starting at noon. And it was clear, looking at this data, that a noon start wasn't the best time to start, and a sunrise start would have probably taken away a lot of this, or moved this curve down on the axis. So Bruce also looked at a warm race versus a cool race, and everything was worse in warm conditions except cramps. And people cramp from not from the heat as much as the exertion of the race itself. So here's 3 races in Boston. This is still under the noon start. It was 2004, 2005, and 2006. And you can see the number of dropouts per 1,000 finishers is almost linear, whether you're looking at per 1,000 encounters per 1,000 finishers, dropouts per 1,000 finishers, or encounters plus dropouts per 1,000 finishers. And the correlation coefficients are close to 1, so it shows pretty clearly that as the heat goes up, the number of casualties go up. And this is from the 2004 Boston Marathon. Wet bulb globe temperature at the start, which was noon, was almost 23 degrees C, and there were 18,000 starters, 16,700 finishers, 1,100 or 1,000 medical encounters, and 1,200 do not finish. So the unsuccessful runner number was 132 per 1,000 finishers. They had over 300 EMS calls, and it caused an area-wide mass casualty incident, which means that they had shut down most of the hospitals in the area or brought them to capacity, which is similar to what happened to us in 2007 at Twin Cities. Is we shut down 6 hospitals, 2 of the trauma centers, with the casualties coming in off the course. And I'll show you what we did with that. What Boston did with this was eventually change their start time from noon to 10 a.m. I think they should have gone back to sunrise or 8 a.m., but there's a lot of politics involved. So here's the marathon in Rochester, Minnesota, which is home to the Mayo Clinic. It's the last Saturday in May. I grew up in Rochester. I know the last Saturday in May can be cold, and it can be really hot. Well, their first race was really hot. They started at about 300 people. They called the race off at 4.5 hours because they'd overloaded the emergency rooms, and there were people collapsing. So they had 139 finishers, and 162 didn't finish. So more people dropped out than finished, and 4 were hospitalized, 20 required IVs, and they had some pretty hot temperatures. Same day in Madison, Wisconsin, the Mad City Marathon started at 32 plus degrees centigrade with 1,270 starters and 788 finishers. The male winner was the same from 2005 to 2006, and his time was 10 minutes slower. They shut down the course at 5.25 hours. They started IVs in somewhere between 50 and 75 runners. They had 8 ambulance transfers and basically went into mass casualty status. One female runner, probably with heat stroke, had some pretty severe seizures, and a male runner was measured at 108 or 42.2 C rectally. In Rotterdam in 2007, this is at 52 degrees north latitude, so much further north than Twin Cities and Boston. The start time was 11 o'clock, and they had a 5.5 hour time limit. They canceled at 3.5 hours. So 20,000 people entered the race. Only 7,800 started because I think a lot of people realized it was too hot for them. They finished about 4,200. So 3,600 didn't finish, and they had 30 or more participants ended up in the hospital and 17 admitted. The weather conditions that day were I would consider very warm, although if you live near the equator, these temperatures are really nothing. So somebody who's running a race in Sao Paulo, Brazil, or Rio de Janeiro may find these temperatures very comfortable, but in Rotterdam it was very difficult with wet bulb low temperatures varying from 69 to 78 throughout the course. Interesting to me is that Chilengo won the race in 2 hours, 8 minutes, and 21 seconds in these hot conditions. But he got through the course pretty quickly and maybe better a heat runner than most of the rest of the people. 2007, I was in London. This is at 51 degrees north latitude, 36,000 starters, 35,000 finishers, 5,000 medical encounters. And in London, all the medical encounters are recorded by St. John ambulance group, so they have all the numbers. And I don't know which of these occurred at the finish line, but they had 75 hospitalizations, 6 hyponatremias, and 1 death from hyponatremia. And what I noticed on site was that it wasn't that hot by standards even in Minnesota summers, but it was hot for London, and it was sunny. And it was the first really hot day of the season, so they had a lot of difficulty keeping up with the number of people who were dropping out. So they had 141 encounters per 1,000 finishers and 161 unsuccessful runners. There were over 1 hour waits at the finish line to get an ambulance. And so when the number of people falling down outstrips your medical community's services, you run into trouble. It would mean that if your mother had a heart attack on that day, the chances of her getting an ambulance would be slim. So this was also a mass casualty incident. Chicago in 2007 this is the same date as Twin Cities. We had our biggest heat incident. Started the race at 22 centigrade, 45,000 entrants, 36,000 starters, and the race was canceled 3 hours and 35 minutes into the race. Now, I wasn't at the race that year because it was the same day as Twin Cities, but the year before I'd been there, and at 4 hours into this race, they had finished 3,600 runners. The year before, when it was about 50 degrees, they had finished 11,600 runners. So the heat had really affected that. Now, despite canceling at 3 hours and 35 minutes, they still had 25,000 people finish. And so when runners get on the course and start to move one leg in front of the other, they're going to keep going. So stopping mid-race doesn't really work very well. You really need to think about, can you stop it before it happens? And they had 66 people admitted to the hospital that day. So what does heat do to the marathon? It decreases performance, especially for slow runners. It decreases the time that people become exhausted, the time to exhaustion. It increases fluid needs. It increases the incidence of both hyponatremia and heat stroke. And it increases the finish line encounter rates. It also increases the dropout rates. So then you have to get those people off the course back to the finish line so they can get back to their hotels. Cold does, very cold also increases the dropout rate a bit, but nothing like heat. And it doesn't really increase in medical encounters unless it happens to be windy and rainy at the same time. So the hypothermia starts to become a problem. So adaptation to heat. The behavioral adaptation is to stop exercising or slow down, but athletes ignore those responses. So it's up to us in administrative positions to try to make changes to guide athletes and guide events in how to work this. Again, where you live makes a difference. So if you're coming from the south to the north, you're probably more acclimated than if you're coming from the north to the south to run, and you get some acclimatization from living in that area. And this is what happens to us at the USA Cup. Hottest week of the year, we're bringing in people from all over the world, a lot of teams coming in from Norway, Sweden, Denmark, Japan, and Canada, and in the States, even Alaska, where this is the hottest weather they'll see for some of them in their lifetime. And you can see what happened to our injury rates with the hot weather. So now we've followed this, and this is 2016. This is our newest guideline for cancellation and modifications. So at yellow flag, we're starting to increase substitution. At red flag, we're starting to decrease the length of the game and adding mandatory. And at black flag, we're canceling everything until the temperatures come back down again. And this was a bitter pill to swallow for the administrators, that they really needed to do this. But to make a lawyer joke, we got a lawyer in charge of it, and he decided that it was time to make the changes. At the high school league, we have the state divided into two zones, a cooler zone and a warmer zone, and we use different wet bulb globe temperatures for those areas. At Twin Cities Marathon, we've taken our data and we have a published do not start level, and we won't start the race if it's above 20.5 degrees centigrade, because we know that we're going to go into a mass casualty incident rate and we'll put the community at risk. So each race might have a different level. A race in Florida may be able to safely start at 22.2, where a race in Minnesota in the fall, where it's unexpectedly hot at 22.2, we can't start. So what do we have coming up? Tokyo, they were very concerned about the heat. They're working on trying to alleviate the heat problems as best they can. They're working on different strategies to try and improve the risk for athletes. And there was a big heat wave that came through, which had 57 deaths and over 18,000 admits to hospitals. And this wasn't in athletes, but in the general population. The temperatures may exceed 38, and they're working on things like road surfaces to reflect the infrared, and opening the doors of the stores along the street to try to have the air conditioning come out onto the street. Not so sure how effective that will be, but these are some of the things they're thinking about. When you look at heat stroke, it's a true emergency. It kills people. You've got a half hour to an hour to get them cool. And my big question is, should we start races and events when the risk of putting people at near death is imminent? And I think that's a kind of philosophical question we all have to answer. I want you to think of heat attack like heart attack. You need to respond quickly. As time is tissue. You treat first and then transfer. What you're trying to do is get them below some critical temperature, some time to minimize the degree minutes under the cooling curve so that you have a successful and good outcome rather than death. The diagnostic criteria, hyperthermia associated with CNS dysfunction, which can be as little as mild confusion to almost psychotic type episodes. The CNS status is more important than the temperature itself. Cool them by any means possible. You know, the immersion is sort of considered the gold standard, but there are other things that work. Falmouth Road Races is a heat lab. They now have over 350 consecutive heat strokes that have survived with their cooling protocol, which is putting in the tub as soon as they can, and they get most people back to normal within 40 minutes. Chicago, I've run the heat deck there a few times. On days that aren't that warm, we're not filling the tubs. We use rotating cool towels. So you dunk an ice towel in ice water, wring it out, and then just move it around the body. By the time you get back down to the foot, that towel has started to warm up already. So you're trying to exchange the heat as quickly as possible. So why is heat stroke more frequent or more prevalent when it's unexpectedly warm? The participants aren't acclimated. The other factor may be that some of these non-thermal factors may be amplified when it's unexpected heat and you're not acclimated. I think it's important for races to consider a do not start level. We know at what level will throw our community into danger, so we have a do not start level. It's also important to remember that heat stroke can occur in relatively cool conditions, so you need to think of it in any downed runner who isn't responding quickly. And think heat attack, just like heart attack. Treat it on site, then transfer. Time is tissue, just like in stroke and in myocardial infarction. Early recognition with a rectal temperature is critical. There's no other body temperature you can do in the field that will give you the right answer. And rapid cooling really reduces that risk of morbidity and mortality. So with that, I thank you for your attention, and I guess we're open for questions.
Thank you. Thank you, William. We have enough time for some questions.
Janos, I paid you. No, I was just kidding. I didn't pay Janos.
Speakers were prepared a lot to actually get some interaction. Okay. Thanks for that, Bill. You'll be aware of the fact that the World Championships are happening at the moment in Doha, in Qatar. And the women's marathon a few days ago, there was a no-start rule of 32 degrees Celsius. Eventually on the day, it was actually hotter than 32. It was 32.1 or 32.2, if I'm not mistaken, and the race went ahead. 40% didn't finish, and as a member of the IOC Medical Commission dealing with Tokyo, should there be a non-start rule, what should the temperature be? And therefore, should the IAAF have let that race proceed at 32.2?
Yeah, so the question is in Doha, where there are extremely hot conditions. The women's marathon started just above what they had set as their do not start. Now, one of the risks of putting it in writing is that it's in writing. And it sets you up, if you don't follow your own rules, for problems. So we debated this when we were setting our temperature at Twin Cities Marathon, and I convinced them that we could set it at the point we did. About a week after we announced that we'd made these changes and that we had a do not start level, the state public health department called me up and said, we like what you're doing, and if you hadn't done it, we would have, and the temperature would be lower. So, was 32 the right temperature? Unless you've collected data over a number of years and have that data to show what the right temperature is, you really don't know. The World Championships, you're dealing with elite athletes, which is a different animal than you and me. I mean, I couldn't, I mean, in 32, I'm looking for someplace air conditioned and a cool drink because it's just hot. And so I think most elite athletes are going to spend time in that kind of condition, acclimatizing to that. But I still think we put them at risk. And I think at 32, you're up there at probably a range that's become more risky for everybody. Even the Marine Corps, you know, the fighting elite for the United States military services has a do not start temperature. And even their elite forces that are acclimated to high temperatures won't start something if they don't have to when it's that hot. Should they have canceled? I think if their number in the sand was 32, that above 32 probably should cancel. But how do you round? And what are the rounding rules? I get this in wrestling weight certification. The weight cutoff is 119 pounds, and the kid weighs 119.2. Why don't you put him at 119? Well, because 119 is the weight certification number, and that's what I use. If Twin Cities Marathon was at 20.6, we would cancel it. But then it's, what do you do if it's 20.4? I mean, how much difference is that, and how sure are we of our data that that's the right lower number? And what we need is some points in between to start to fine-tune that number. And I think that's what, you know, track and field and other sports organizations need, is to start to track the data in those hot temperature conditions. And I would say that 32 at the London Marathon would be a disaster, or probably a catastrophe. But 32 in Doha, for people who live there and work out there all the time, it might not be quite as bad. But a 40% dropout rate is really high. Now, it might be that 40% looked at the front of the pack and said, not getting there, and said, I'm stepping out because I got another race in a month where I could win $50,000 or be in the majors for something. So it's really a lot of variables that go into the individual decision to start, the individual decision to stop. But I think what we're dealing with is, what's the administrative decision to let them go out? And should we let people go out when we know that 10% of the field may end up with heat stroke? Is it that important that the race goes on despite a high temperature? So it's kind of a long-winded answer to that, but I don't think it's a simple yes, no, black and white thing, although I think we almost have to treat it that way to stay out of trouble in the courts and other areas.
And I think the call for data is important, and the good thing about the Doha race was that we have implemented core temperature measurement using the pill. So basically we'll have excellent data from Doha, and therefore they can be used in Tokyo as well. So I think, as you said, data is needed so that we know, is it that dangerous actually in elite athletes who should be prepared? Yeah. It's a different story for the mass population. Yeah. So
Giannis is referring to the temperature transducers that they'll be internal in these racers, so they'll be recording their temperatures continuously through the races, so we'll start to see what's happening to people. And where that's been done in bike racing, there are people who maintain temperatures in the 41.5 range for long periods of time who are walking and talking, and you wouldn't know their temperatures were that high. So there's got to be runners doing the same. But what percent? At what point do they go from, is it from 41.5 to 41.6 and all of a sudden they're on the ground? Or is it, how long are they exposed to that? You know, we really don't know. It's really a black box. And the wearables that Giannis talks about really will make a difference in how we can assess what's happening with athletes in lots of conditions. So I think it's really exciting, and it would be nice to see that data when it comes out.
Thank you, Williams. Another question. Two questions from Diane.
So the saying is treat first, transfer later. So in our situation at Twin Cities Marathon, we have the ability to check serum sodium and a few other electrolytes. At a football high school stadium, you probably are just going to cool them and send them to the ER and look for those things. So that immediate cooling is the heat stroke aspect of it. Whether you can get labs on site or not really depends on how much money do you have to purchase or use those devices that are available, but can be expensive.
Thank you for that really complete data on a number of marathons. I have a question as well about the balance between pre-hospital care and hospital care. You talk about these mass casualty events and situations where EMS can be overwhelmed. And I think one of the conundrums that I see in this area is that oftentimes the best treatment, the most effective temperature lowering, is more reliably done on site than in an emergency room. In my area, it's the rare emergency room that can do cold water immersion or can do a proper heat deck treatment. And so I wonder if you could speak a little bit about your thoughts about when to transfer and who to transfer in these situations where you might have a situation where in an event you're going to be treating hundreds of heat stroke casualties in a day.
And that's a really good question. And so the question is, where do you draw the line at pre-hospital care and transfer to the hospital? And I think in heat stroke, your best strategy is to cool them on site. That is, cooled on site, you reduce the number of degree minutes under the curve. Anytime you put somebody in an ambulance and transfer them, you could delay cooling by anywhere from 20 to 90 minutes, kind of depending on how fast they go. In our region now, because of what we've done with our races at Twin Cities in Motion, the protocol as a runner down the street is cooled whether they check their temperature or not until they get them to the hospital where they can check the temperature. So we're seeing less severe heat stroke in the ERs. But when you have a large group of people and the ER capacity is limited and you want to leave it open for the community, if you try to transfer everybody that you suspect to have heat stroke to the ER, you'll start to have problems in the ER itself. And as the questioner suggested, a lot of ERs aren't prepared for doing rapid cooling, especially with tubs. I know in Boston now, they buy tubs, they give them to the ERs on race day. They have one of their staff people there on site to help with the cooling. But I also know from the Vikings player Corey Stringer, who died, that going to a small community hospital in a small town in rural Minnesota with a temperature of 108, you're probably going to die. So it makes a difference how prepared you are for taking care of that. And that's why, with cardiac arrest, get them to the hospital as quick as you can, because that's where you can make a big difference. But for heat stroke and even for exertional or exercise-associated hyponatremia, the treatment you do on site can save them. And what my ER friend says, it saves them from the donut of death. That is, if you go into an ER with CNS changes, they're going to send you to the CT scanner, which takes 40 minutes. So in that time, you die from hyponatremia and you die from heat stroke. So it's important, I think, to be able to treat on-site, especially in large mass casualty situations. So thank you for that question.
Another question?
Thanks, Bill. I guess building on previous questions, there's been a lot of controversy in the literature recently about definitions of exertional heat illness, exertional heat stroke, exercise-induced hypertension. From a physician's point of view in the field, do these definitions concern you and drive your practice? And what's your interpretation? I mean, do we not refer someone to the emergency room if their core temperature is below a certain level when they come to the sort of medical tent in the field?
So who do we refer to the emergency room from the field, and what are the definitions that I use for heat injury? So my basic differential is, are they breathing and do they have a heartbeat? Yes. Then I move down. Is their temperature elevated? Yes or no? If yes, then cool. If no, then I check a sodium. And if the sodium's okay, then I put their feet up and give them some time. And a lot of times, people who come in, by the time you've done all those things, if you need to, they're starting to wake up anyway. So that's the postural hypotension. And that's the 4 basic things that occur, and that's the order I look for them. Heart's not beating, get an AED on them, get them in the ambulance, get them to the hospital. Temperature's elevated, cool them off as fast as you can. If they're not responding, check their sodium. Temperature's okay, it's still goofy, check their sodium and give them a hypotonic saline. So we'll give 100 milliliters of 3% saline as fast as we can, and if they aren't waking up, we'll do it again. And I think the sort of the world record is 10 boluses of 100 milliliters of 3%. So you can do that safely in people who are acutely hyponatremic. So think of it like kids who have bad vomiting and bad diarrhea. You treat that hyponatremia rapidly, whereas my mother with a sodium of 122 who has inappropriate ADH, if you do that, you'll kill them. So it's a different mindset, but the field treatment, I think you do what you can in the field to reduce the number of people that go to the hospital. And sometimes it's really hard to tell the severe exercise-associated postural hypotension from heat stroke and hyponatremia. Cardiac arrest is the easy one. So if you get there quick enough, we can save them, but that's the easy one. The other two are more difficult.
Okay. Well, we finished the session before the scheduled time. This is very great. And let me say thank you to all the speakers for the beautiful scientific work. And goodbye. Now the break.
Thank you.
Naj gre za dolgo ali kratko pot. Zdaj lahko poskrbim za svojo družino, ker moje gorivo poskrbi za moj avto. Izboljšani dodatki v gorivih MOL učinkovito zmanjšujejo obloge in tako čistijo motor. Z novo generacijo goriv MOL Evo poskrbite za motor vašega vozila.
Thanks so much for the introduction, Yanis, and pleasure to be here, and thank you to the organisers for inviting me, and also to BASM for supporting certainly travel expenses to be here to share with you today. So in my laboratory we do a lot of research in people with quite severe physical limitations, physical disabilities, and look at how we might be able to help manage, prevent cardiometabolic disease, particularly in these populations. But I think what you'll see as we go through today's talk is that this is not just relevant to these severely disabled populations. Actually, there are lessons we can learn here about how we manage patients with even relatively minor limitations. And certainly some of our work now is looking at people with relatively moderate knee osteoarthritis and how we might be able to intervene to help them manage, which is becoming a cluster of cardiometabolic disease risks over time. So pleasure to be here today. Let's get stuck into the content. So what I'm going to cover in the talk, I'll briefly introduce cardiometabolic health and disease, just for those people that are less familiar with how we define such characteristics. We'll look at specific risks in some injured and disabled populations, and particularly we'll look at a model for low energy expenditure disability deconditioning syndrome, which is, as I say, a particular risk to a wide and broad range of humans. We'll look at some of the current physical activity guidelines, how effective they are, and I think we'll finish with what is hopefully some really strong and emerging evidence of why we might want to move on to think about higher intensity forms of exercise, including resistance training for these sorts of populations. And hopefully you're all writing down your questions so that we can have a thorough discussion at the end. Before I get stuck in, I just wanted to introduce, and I know Natasha Jones will talk about this more later in this series of lectures, about the UK's Moving Medicine Initiative. I only came across the initiative around a year ago, but I have to say since I've been involved in helping them recently develop a new module for moving medicine in low limb amputees, they're doing some fantastic work, and work which will cut across all boundaries of humankind. Really what the initiative is about is improving conversations between patients and practitioners, and not going in with strict exercise guidelines, but improving the conversation to how we can get people to live more active and fulfilling lives. And I think the important thing to recognise, and something which will come up as a recurring theme in today's talk, is yes, to get the minimal benefits out of physical activity, we only need to move people a little bit along the spectrum into becoming slightly more active. But actually, when we've got populations who have significant barriers, disabilities, limitations, how do we make the most of the time that they do have to give over to physical activity and exercise regimes? And that's something which we're focusing on. Something in Natasha's presentation which hit me quite hard is what we're still really fighting, particularly in the UK, and I'm sure this is true in many other countries, is this sort of Victorian legacy of bed rest. Rest is best. And, you know, it was only a few months ago I was visiting a spinal rehabilitation centre in the UK, and they're not unique. I'm not going to mention which one. But actually, this is still so true. Let's put people in bed. They're recovering from an injury. But actually, these people are stable after several days and at least within a few weeks. We should be getting them active. We should be doing much more with them during these extended periods of inpatient rehabilitation so that we're introducing good, strong behaviours that they can take forward when they return home and live active and fulfilling lives with. Okay, so let's just quickly talk about cardiometabolic syndrome because these people and the risk that they accumulate after periods of bed rest and inactivity do give rise to risk in this area. Starting point is these people start to gain weight and particularly body fat and we've got a good definition of obesity within the cardiometabolic syndrome guidelines. They also, as a secondary consequence to inactivity and obesity, start to become hyperglycemic and develop risk factors for type 2 diabetes. What then follows is the dyslipidemia and the higher risk of cardiovascular disease and endothelial damage as we move forward. So these things are all fairly well defined within various guidelines across the world, but the one we tend to use is the World Health Organization guidelines. So when we start looking at some of our specialist populations who are forced into a life of inactivity, or so it seems, what do we see? Well, within the spinal cord injured population, they have a 34% incidence of cardiometabolic syndrome, characterized by central obesity, low high-density lipoprotein concentrations, a high incidence of insulin resistance or diabetes, elevated triglycerides, and of course hypertension. So over a third of the spinal cord injured population, given that these people are often within 10 years of their injury, are now living with cardiometabolic syndrome and heading towards much more severe circumstances. If we look at some of the DEXA scans we've taken of some of our obese middle-aged individuals, so you'll see in panel B, we've got an obese middle-aged woman here. And we've got an age-matched spinal cord injured individual in panel A. The reason I wanted to show this is because this is not just about obesity. We've also got a secondary problem with a lot of these physically limited populations, and that they lose a lot of muscle mass, and they lose it rapidly. And that means they've got less metabolically active tissue in which to achieve good metabolic health. And that tissue is important in regulating both metabolic and cardiovascular function. So you'll see in the lower limbs of the spinal cord injured person on the left-hand side that we've got an almost complete loss of lower limb muscle mass because of the lack of innervation. So we're fighting against some of these things constantly where we're trying to intervene and manage the health of this population. So they're 4 times more likely to develop type 2 diabetes and twice as likely to suffer from cardiovascular disease. So cardiovascular disease is now the leading cause of morbidity and mortality following spinal cord injury. And not surprisingly, cardiorespiratory fitness has a strong inverse association with mortality. So we should be doing whatever we can to try and preserve whatever cardiorespiratory fitness they do have left. And that's one of the primary aims of some of our work. Let's just have a look at the lower limb amputee population then. How do they fare? Well, of course, we've got very different lower limb amputee populations. The vast majority in the UK are due to perivascular disease secondary to diabetes. They have 4 times greater risk of future cardiovascular disease mortality, certainly among the bilateral lower limb amputee population, and characterised by the typical obesity, hypertension, hyperinsulinemia and diabetes. So how does this come about? Well, certainly low activity levels have got something to do with it. The loss of active muscle mass is certainly important, and some of the research we're doing is looking at how muscle mass itself is helping to regulate inflammatory processes, which you'll see further down. And certainly that does seem to be important. There's an accumulation of visceral fat and the systemic inflammation which ensues. I think this was really nicely captured by Jim Rimmer, and if anybody wants to look further into this, the disability-associated low energy expenditure deconditioning syndrome. It's a bit of a mouthful, but actually it's a really nice model to explain the consequences of disability and low activity levels. And you'll see in the middle panel the physiological effects in terms of increased disease risk, in terms of interference with metabolic pathways and cardiovascular pathways. But you can also see some of the outcomes, some of the very real outcomes in terms of, at the bottom there, increased reliance on personal care assistance, decrease in community participation, increased healthcare utilisation and cost, and ultimately decreased quality of life. And you'll see on the figure on the right-hand side there, if we look at the cardiorespiratory fitness levels of some of our disabled populations across the world, they're in the very lowest levels. 10 to 15 mils per kilogram per minute VO2 max is the sort of VO2 that most of us would experience walking to the shop. These people are at VO2 max at these sorts of levels. So again, we need to do whatever we can to maintain their cardiorespiratory fitness. Low activity, loss of function. You can see the collection of cardiometabolic risks here, but not just cardiometabolic risks. I mean, I won't talk about it today. I haven't got time. We'll talk about it at BASM in Glasgow later in the year. But we've got real issues with osteoporosis, particularly now that people are starting to try and use exoskeletons. Well, with people that have been disabled for 5+ years, the loss of bone mass is rapid, and these people have a high risk of fracture. So we need to be very careful and very aware of the potential other risks. We certainly can't also rely on traditional risk factors. So if we look at the accumulation of body fat in spinal cord injured individuals, we can see both in paraplegic and tetraplegic individuals, the accumulation of body fat in the arms, in the legs, and certainly on a whole body level is significantly higher. But what that means is because they're losing muscle mass at the same time, we can't rely on things like body mass index to give us even a feel for their body composition. If we look at the figure on the right-hand side, if we take a normal control population in the black circles and we take our spinal cord injured individuals in the white circles, we look at a BMI of 30, you can see that the control participants have got a body fat percentage of around 25%. That's equivalent to around 40% in our spinal cord injured individuals. So we have to look at their risk in a very different way, and we have to measure their risk in a very different way. As I say, a lot of these changes occur very rapidly, and certainly with spinal cord injury, there's relatively little we can do about some of the short-term consequences until we start engaging with technology. So if we look at panel A at the top of this slide, this was a spinal cord injured individual. This was a scan on entry into emergency care. And if we look at the scan just 6 weeks later, you can see the loss of muscle mass and the fat infiltration into that skeletal muscle tissue. That's occurred just in 6 weeks. With the intramuscular fat content, that continues to accumulate up to around 6 months, by which stage a lot of the cardiometabolic disease risks are fairly well set in. So intervening early is going to be key in these sorts of populations. Of course, we can start to use things like electrical stimulation to try and maintain the low limb muscle mass. And some of my colleagues over in Miami now are starting to use pharmacological interventions. They're in early trial stage, but things like myostatin inhibitors to try and prevent the loss of muscle mass during these periods of deconditioning, whilst we look for better solutions longer term. So just how active are this population? Well, certainly for spinal cord injured individuals, if we look at their daily physical activity levels, this is basically estimating their activity as a proportion of their resting metabolic rate. They're incredibly low and way below the World Health Organization recommendations for minimum physical activity levels. So we've got a control population on the right-hand side, which is the recommendation of the World Health Organization, and we've got 2 studies, including one from my lab, measuring physical activity levels. And these are not particularly inactive spinal cord injured individuals. These are quite highly motivated individuals, but it's very low. We then went on to look at, well, what's the cardiorespiratory fitness of spinal cord injured individuals if they do maintain some kind of physical activity. And we used physical activity monitors to give us some objective data. And we had individuals who did less than 40 minutes per week of moderate to vigorous physical activity. They were in the lowest category for VO2 peak. But then we had the people who did more than 150 minutes per week, and actually they maintained fairly reasonable levels of physical activity. But for a population with these kinds of limitations, the stimulus has to be particularly high in order to even maintain these levels of aerobic fitness. And in the lower limb amputee population, we have less data, but actually the message is still the same. People with lower limb absence are not participating in physical activity conducive to health benefits. Only a minority participate in exercise and sport, and they experience a lot of barriers which are difficult to overcome and are not currently being challenged by them, by their practitioner, and by the people around them, partly because of this Victorian legacy of bed rest. We need to get these people out there, and we need to be adapting sport and exercise so that they can engage much more readily. One of the things we did with our lower limb amputee population is we said, well, actually, are these risks accumulating because these people are just not doing enough physical activity, or are they accumulating because there's something inherent about their condition, about the loss of muscle mass, about the way their body's now regulating, which gives rise to an increased risk? So one of the things we did is we started working with our colleagues at the Defence Medical Rehabilitation Centre, and we said, well, let's take a lower limb amputee population who are doing around 12 hours per week of quite intense physical activity. So these people are doing 12 sessions per week of group exercise, often in the gym, doing resistance, circuit-type resistance training. They're also doing 3 sessions a week of swimming and other types of therapy and conditioning activity. So it's quite a high stimulus. So, how are they responding? So what we've done is we've tracked them over a period of time, and this is new data. We've only just finished analysing these. We looked at their physical activity energy expenditure as an objective marker of their activity levels. And you'll see in the unilateral amputees, in the black bar, when they're inpatients, they're just as active as the controls. We're actually maintaining really good levels of physical activity. That drops off a little bit when they go to their home environment, when they're outside of the residential rehabilitation environment. But actually, it seems that we're embedding some fairly good behaviours that they're then maintaining into their home environment. The bilateral amputees we're doing less well with. They're only about half as active as the controls and the unilaterals when they're inpatients, and that drops off significantly when they go home. So their physical activity levels are very low when they're in the home environment. Or as some of the senior military officers like to call it, soldier on the sofa. So these people have not been particularly active. We then looked at some of their body composition characteristics over time. And I think the really encouraging thing is that for our unilateral amputees in the white circles here, their body fat percentage is not really changing and accumulating over time, and it's pretty similar to the control participants. And importantly, their visceral adipose tissue in the right bottom panel is being fairly well maintained at low levels. With the bilateral amputees with the lower physical activity levels, these people have been in rehabilitation for about 3 years. They've already accumulated quite a lot of visceral adipose tissue, and they're starting to show some of the signs of cardiometabolic syndrome that unfortunately we do anticipate. So the physical activity and the maintenance of it seems to be particularly key in reducing risk in these populations. But we also have to recognise that not all activity is the same. And some of the work we do in our laboratory is we try and characterise physical activity in different ways. We try and measure it. We try and give real-time feedback to participants to try and motivate them to achieve different goals. Our hypothesis is that actually it's the moderate to vigorous physical activity which is particularly important in terms of metabolic regulation and staving off diabetes. We've got 2 examples here. These are real data from some of our studies. We've changed their names, Bill and Ben. And they've got exactly the same physical activity levels, 1.68, 1.69. But they've got very different physical activity profiles. Bill does 80 minutes per week of moderate activity, 20 minutes of vigorous activity, but he has about 12 hours a day of sedentary time. So this is the sort of person that goes to the gym, he exercises hard, he goes home, he sits on the sofa. So for Ben, very different. He's much more of a fidgeter. He only does 10 minutes of moderate activity and no vigorous activity. All of it's low level. But actually, he has a fairly good physical activity energy expenditure. He only spends 5 hours a day of sedentary time. The physical activity, the exercise prescription for these two individuals should be very different. What Ben needs is a good, hard, intense metabolic stimulus every day, and what Bill needs is just to be a bit more active when he's not at the gym. So there's some of the things we're sort of toying around with. This is how we personalise our exercise interventions and prescriptions. What we need to be able to do that personalisation is we need objective tools so that we can measure physical activity and provide feedback. And we've now done this, so we now have validated equations to calculate physical activity energy expenditure. We can calculate moderate to vigorous time. We can do this for spinal cord injured people, we can do it for lower limb amputees, and of course we can do it for the general population. The reason why we've had to do it differently for these populations, of course, spinal cord injured individuals spend most of their time moving in a wheelchair, so it's upper body movement that we have to characterise. And with lower limb amputees, their gait is very different from the general population, and we have to characterise that very differently as well. And that's this paper here, which was published in 2017. So we're able to do that now. We're starting to get a sense of the fact that more intense exercise is particularly important in maintaining cardiometabolic health. So it's actually quite disappointing when we see exercise guidelines coming out for these populations, which really give a very low stimulus. They ask for, to maintain fitness, only 20 minutes of moderate to vigorous intensity aerobic exercise per week, and 2 sessions per week. They don't even define what moderate to vigorous means. So how is a patient or a practitioner supposed to really engage with these guidelines? And for the maintenance of cardiometabolic health, they recommend a little bit more, but still, is the stimulus enough? It's certainly ill-defined, and we've started through some of our studies to challenge these guidelines, because it's not that we have a problem with the people who wrote the guidelines, because I think what they've done is they've based the guidelines on the best available evidence, but the evidence needs to be better, and they admit that within their review. There's been some studies done which have challenged this. So this one by Tatotsi Dezapetnik. They basically had individuals follow the spinal cord injury physical activity guidelines for 16 weeks, 32 sessions of 60 minutes per session, including cardiorespiratory fitness training and resistance training. And the only thing that really changed was they stopped the increase in waist circumference and BMI, but there was no impact on any of the cardiometabolic disease risk markers. That's a sign to me that there's something not right about the exercise stimulus, or this patient population are not going to respond very well at all. So you'll see on the right-hand side what we saw in this study was very moderate effects on some measures of body composition, but over 4 months of exercise, one might have expected a bit more of an impact on some of the biomarkers of cardiometabolic disease. The response to this kind of evidence and these kinds of guidelines has been quite aggressive, with people calling for upper body exercise alone is not enough. We need to be thinking about electrical stimulation. We need to be starting to think about pharmacological interventions. We need to be thinking about reducing sedentary behaviour, but particularly we need to be thinking about dietary intervention. We can't just see exercise guidelines in a little volume by themselves. We need to be thinking about it as an integrated approach to lifestyle management. Certainly the later guidelines that have come out through various reviews are suggesting much more physical activity, and these are suggesting a volume of around 150 minutes per week for disabled individuals, which I think is probably closer to the mark, but still exercise intensity is not particularly well defined. So what we've done in our studies is we've taken this to a bit of an extreme, and we said, well, let's train people at home for 6 weeks. We're going to give them 4 45-minute exercise sessions per week, so 180 minutes per week of moderate to vigorous activity. And they're going to do this at 65 to 70% VO2 max on an arm crank ergometer. and we saw a 17% increase in VO2 peak, so we're very pleased with that just in 6 weeks. That's equivalent to, if you look at the risk calculators, 15 to 19% reduction in all-cause cardiovascular disease mortality, so quite substantial. What we were less impressed with, again, was some of the responses of the cardiometabolic disease risk biomarkers. What we saw was an improvement in resting fasted insulin sensitivity, so that's good, pleased with that. But what we're not seeing is an improvement in postprandial measures of insulin sensitivity. So how are we handling the foods that we eat, the carbohydrates that we take on board? Because most of us spend most of the day in a fed state, so that's important to think about. Again, what we were impressed with was some of the other measures we took, which as physiologists we're not prone to taking, but we were advised to for this study. And in just 6 weeks, we saw significant improvements with the intervention group in perceived vitality, their perceptions of fatigue, their general perceptions of health, and their role limitations, how limited they felt due to their physical health. So some really important improvements in this patient population. And we see the same in the low limb amputee groups that we work with. If we look at the groups that we work with defence, you know, we're getting these low limb amputees back to normal ambulatory levels where they can, you know, fit back into the community and they can perform sport and exercise alongside the general population with relative ease. The problem we still have is this bilateral amputee group, and again this is back to this study that we've just finished. If we look at the central column here, the bilateral amputees, we've got significantly raised levels of total cholesterol to HDL ratio. We've got triglyceride concentrations which are elevated, C-reactive protein elevated, etc., etc. There's a whole host of biomarkers which are still elevated in this group, despite the fact they've been engaging in the most intense physical rehabilitation program that they can. So still a real challenge for these significantly impaired individuals. So on the back of all of this work, what we've started to do is really challenge some of the guidelines and say we should be looking at raising the intensity of exercise. I'm going to race through a couple of my slides because we're short on time. But essentially what we've done is we've demonstrated through our studies that if we give people an exercise dose where the prescription of intensity is around 70% VO2 max or higher, then whether it's arm exercise or running on a treadmill, if they're able-bodied or disabled, the actual ability to maintain metabolic function is still as strong. So even with a relatively small muscle mass involved in arm cranking, we can still maintain insulin sensitivity when these people are under threat. We shouldn't be afraid of high-intensity interval training and things like this. The risks in many cases are no higher than general exercise, but certainly this is an area that we're starting to progress and work in now, alongside circuit resistance training. So we're just about to publish a study I did at the University of Miami while I was on sabbatical. And if we look at some of the improvements in cardiometabolic disease risk, again, equivalent to a CVD risk reduction of around 25%. This is with 3 sessions per week of circuit resistance training. That's been incorporated into the Paralysed Veterans of America Clinical Practice Guidelines. And what we're working on now is how can we make high-intensity interval training fun for people. And the way that we're doing this, or one of the ways in which we're doing this, is we're starting to work with our colleagues in our computer science department. We're developing virtual reality exergaming solutions. This is our first run at it, so please forgive me, it's quite crude, but the participants do enjoy it, they do engage with it. We need to start building in different levels of achievement now. But you'll see this is just the wind-up phase. We'll get the countdown as we approach 0 seconds, as we move into the high-intensity interval phase, and you'll see the changes in the scenery, the background, the police cars chasing you. The other thing we can do with this, and we've got on this screen here, is you see the bike that's just moved off to the side. That's their ghost avatar of their previous performance. So we can manipulate that and we can get them racing against their previous performances so that we can try and maximise their effort during these sessions. The patients that we used for this study said they enjoyed doing this much more than you see the sprint coming now. They enjoyed doing this much more than traditional forms of 45 minutes of slogging away on an arm crank ergometer. And it seems to be just as effective, if not more effective, for their cardiometabolic health. So we've got some work to do on fine-tuning these protocols and programs, but I think what we'll see over the coming years is a real move towards getting people to exercise more intensely to manage their disease risk as we move forward. So if I leave you with one message today, it's please don't wrap people in cotton wool, whether they're injured or not. Let's get people out there engaging in higher intensity forms of exercise because it's much better for their long-term health and well-being. And I'd just like to leave thanking my colleagues and collaborators, and thank you all for listening today. Thank you.
Thank you, James. I was reading on the BBC website this morning how a paralyzed man was able to walk using his mind and an exoskeleton. So quite interesting. Yeah. Open to questions. Natasha. Just put it closer.
Can you hear me? Really interesting talk, thank you very much. In terms of extending this to the lower limb amputee population, particularly the medical amputee population who clearly are very different from the forces population, how do you think high intensity exercise is going to apply to that population? Because clearly the muscle mass and muscle issues are the same.
I think it's a really good question. I mean, the patients we used in our studies are from that population. I think what we can do is we can get them interested enough to have a go and developing a protocol that these people can do high-intensity interval training on. Yes, the intensity is lower than it would be for a more able population, but it still provides the same relative stimulus. And I think if we can get them hooked enough to do, let's say, a 6-week intervention as we've done, they'll feel the benefits and they'll start to become motivated to sustain the behaviour. But I think it's just about adapting the protocol so that these people can at least get off the ground with these kinds of protocols. But it's definitely possible. Yeah.
Other questions? While you're waiting for a question, James, could I? It came across quite strongly the issue of dose. Of the exercise, the intensity, the amount, and so on. Could we get a clue about what is the right dose? Because I think we have the same problem with the able-bodied individuals from the Paralympians. Because these individuals are training hard. They are elite athletes. They're doing amazing things. Could we get an access to the dose that way? And I ask this because we were looking at physical activity levels in young children in Europe in an EU-funded project. We couldn't find active children. So we went to Kenya and studied these kids and found that the MVPA was 240 minutes a day at least. Yeah. Could you use the equivalent would be, let's say, your Paralympians? Is that something to think about?
I think it'd be really interesting to have a look at those data and compare. I suspect that what we've got there is a population who are right on the limits of what they can sustain, because I mean a lot of Paralympians, for example, struggle with shoulder injuries long term. But I think what we can do is learn some lessons from, particularly if we look across the different types of Paralympic sport. What sort of doses and intensities of exercise are these people getting, and how is it helping them to maintain their body comp. So, for example, I know that the wheelchair racing athletes tend to have very good body composition, but actually if you look at some of the other Paralympic athletes who are involved in more strength and skill-based sports, they actually still struggle with maintaining their body composition. So we could get some clues from these different types of subpopulations in the Paralympic population in terms of how well they're maintaining their overall health and well-being. Yeah.
Thank you. We have time for one more question. Let's use the time. At the back, please. If you just wait for the microphone so we can all hear you. Thank you.
Thank you for a nice presentation. So there are some reports that in some 20 years there will be surgery able to recover the spine. So do you think it is also possible to maintain the muscles, joints, bones in a good condition, so the people that are already injured now, they will survive till then and be able to use those advances?
Thank you so much, because we had a lot of those discussions whilst I was working at the University of Miami. So the department I was working in was the Miami Project to Cure Paralysis. and 90% of the focus of their research is on trying to find a cure for spinal cord injury. And there's some really neat work going on. But actually, in the meantime, whilst we are waiting, and they're under pressure because they promised 20 years ago that they would have a solution by now. So in 20 years' time, we might be closer. But I think in the meantime, there's a lot of spinal cord injured individuals who are hoping it will happen in their lifetime. And what we need to be doing is working with these people to, as you say, maintain their muscle mass, maintain their bone health, maintain their body composition and their activity status, so that when that time comes, they're in a good position to benefit from the therapy. But I hope it will come sooner than 20 years, but who knows? Yeah, thank you.
Okay, I think that's time up. Please join me in thanking James. Okay, so I'd like to invite James to co-chair the next session with me. I'm particularly excited about this Intercontinental Symposium. I think from the program it has the potential to be one of the most exciting symposia. Why? Because it's dealing with arguably the biggest threat to mankind, which is the starvation of physical activity, and how can we actually deal with this in a concerted effort. And those of you, I presume all of you who at the opening ceremony would have heard both Professor Picossi, the president of FIMS, and also Dr. Casasco, both in their presentations talk about, we need to think out of the box, and this notion was thrown up in the air about having potentially a global alliance, which is something a lot of us are interested in. So it'll be quite interesting to see what's happening in different parts of the world. We have a real dream team again for the symposium. We'll hear from what's happening in Asia, in South Africa, in Great Britain, and so I expect a real treat as well for this particular session. So let me invite, therefore, and the USA, sorry, of course, our next speaker. So let me invite, behind me already, Bill's ready to go. I won't introduce him anymore because you know who Bill is, and rather let's spend the time on his message. So over to Bill.
Well, thank you, Giannis, as we get the slides ready to go here. I'm honored to be here. I thank the organizing committee for inviting me. I was just out on the walkway, walked a little further than I planned, just got back. It's very nice out. I'm happy that you're here on such a beautiful day. This is a lot like Minnesota. As soon as it gets above 60 degrees and the sun comes out in the fall, everybody takes their jacket off, rolls up their pants, and goes for a walk. So there were a lot of people out there. So I'm going to talk about exercise as medicine, what I'd call preventing the diseases of inactivity, from a perspective of a member of the American College of Sports Medicine. The Exercise as Medicine program was the brainchild of Bob Salas, who followed me as the next physician president of the American College of Sports Medicine. And his vision was that we would move exercise into a part of the arena that would be taught in medical schools, used daily by physicians, taught to patients, so that we could begin to promote healthcare and physical activity in our own healthcare settings, and start to consider physical activity as a vital sign, just like blood pressure and weight and pulse. So that's been a lot of his goal, and I share that with him. What we need in the end is to provide our patients with some kind of recommendation on physical activity. And if you talk to a lot of patients, no physician has ever talked to them about physical activity and their health benefits. We also need to utilize the professionals out there who can extend our reach. And we call it the interprofessional healthcare team in our system, and that includes the exercise professionals who can help us with the actual delivery of exercise training. So you can also be a champion for physical activity in your health system, and I think it's really important for us to be role models as in the community. And almost all my patients knew that I ran at noon, because every day I would run at noon, come back and shower, and then finish the day. And that kept me going, but also put the message out to them that I was doing what I preached. So I think that's important to role model your activity for your kids. George Sheehan was a cardiologist who wrote a lot of pieces in the late 70s, early 80s. He published in Physician and Sports Medicine and in Runner's World. And one of his essays was titled "Every Patient is an Athlete," just in different stages of training. And I've adopted that very early on in my practices as how I would approach patients. That is, every patient should be physically active in some way. We spent a lot of time and money working on removing the weapons of mass destruction, but we haven't spent as much time as we could working on the weapons of self-destruction: tobacco, excessive food intake, sugar, and particularly inactivity. And I think inactivity is the part that's been added to this list with this movement around the world to incorporate exercise into healthcare. When you look at what we do as physicians and health providers for the overall health of our patients, this contributes about 10% of the diagram of what affects health behavior and what affects the final outcome in health. And that 10% is really a pretty small percentage. What really makes the difference is the 50%. That's the health behaviors that people have with diet, exercise, and smoking. And if we could get everybody to exercise every day, eat sensibly, and not smoke, I could be out of a job, which, well, at my age probably isn't a problem. But anyway, there are a lot of things that we can do to influence that 50% that we can't do with that 10%. And that 10% that we do deal with is a lot of chronic disease that is a part of exercise deficiency. When you look at exercise deficiency in the U.S., it's increased. It's a relative risk similar to for cardiovascular disease to tobacco use. So being inactive is unhealthy, and trying to get that message across is a big part of exercise as medicine in the U.S. When you look at Frank Booth's articles on chronic disease and primary prevention, this is a list, and this is the list of most of my patients: obesity, insulin resistance, hyperglycemia, type 2 diabetes, triglyceridemia, increasing blood pressures. That would be the problem list of probably 90% of the patients that I see in my clinic every day. And a lot of it is brought on by inactivity and not getting out and about like they should. So there's a long list of harmful side effects to inactivity. And push the wrong button here. There we go. And exercise is really a fabulous tool both for the treatment and the prevention of chronic disease, which includes obesity and premature death. And there's a linear relationship between physical activity and your healthcare status. And the association between disease and inactive, unfit lifestyle persists across all subgroups in the U.S. and probably around the world. So physical activity, as Steve Blair would say, is the major public health problem of our time. And I think it's the one that it's easily solved if people would move, but it's very difficult to get people who aren't used to moving again. So Frank Booth suggested there's a gene in the human genome that's obligatory, that physical activity turns on or off. And to survive as a human, this gene has to be working. And the metabolic pathways that were selected during evolution are linked to physical activity. So the body protects itself during times of activity and inactivity to set up the functional outcome that is appropriate for the environment that we live in. And unfortunately, the epigenetics of what we're doing with our populations now, with our kids and inactive adults, turns on and off the wrong genes, so we are storing more fat and becoming less active. If you look at obesity in the U.S., and this doesn't go back far enough, I was in elementary school in the 50s. And in the 50s, this 1990 map would have been mostly white or very, very light blue, especially in Minnesota. There was one kid and I can still remember his name, who was overweight in my elementary school classes. And I could tell you his name, but I won't. He may be in the audience. I doubt it. But you can see how this has changed. That they had to move away from blue and go to browns and oranges and reds to take into account the changing prevalence of obesity in the United States. And the unfortunate thing with diabetes is that it goes hand in hand with type 2 diabetes. With obesity, it goes hand in hand with type 2 diabetes. So you can see just in a 3-year period from 1997 to 2000, there was a 12% increase in diabetes. And you can see that reflected in the map related to diabetes in the decade of 1991 to 2001. So I'm pretty sure the doctor who told this guy to get a dog, because people with dogs tend to be more fit, and buy a treadmill, didn't intend that he walk his dog on the treadmill while he watched TV and drank Coca-Cola. But that's how it's interpreted at times. And unfortunately, the treadmill often becomes the coat rack in many households. Sort of the start of this physical activity began with Morris's paper in the Lancet, where he looked at drivers and conductors in the London buses. And London buses are 2-story or two level, and the conductors walk all day up and down the stairs and around collecting tickets, and the drivers sit and drive. If they were smart, they would change off every hour, but the higher paid guy sits around and dies earlier or has a heart attack earlier than the guy who walks around. So when I work my assistants really hard in the clinic, I tell them they ought to be paying me for the exercise that I'm giving them every day. And they don't think that's very funny. Anyway, there's many studies in many different sources that reproduce this to build what I would call the descending staircase pattern of disease reduction across many diseases, going from inactive to very high activity. There's some recent data that suggests that high activity may cause problems, but I don't think it's anything that we should be worrying about for our patients we see in the office. It may be a problem for some high-level endurance athletes, but I don't usually bring that up. But if you want to reduce your cardiovascular disease risk, your risk of sudden cardiac death, exercise more. I was encouraged by this study, which was titled the Weekend Warrior Study. It came out in JAMA Internal Medicine a couple of years ago. This was a cohort study of nearly 64,000 people and 500,000 person years of follow-up. So big numbers. And there were 4 categories: inactive, insufficiently active, weekend warrior, and regularly active. And I think in our culture of sports medicine, we often poo-poo the weekend warrior, but when you look at this data, that using the outcome of death from all-cause cardiovascular or cancers, it decreases the hazard ratio for even the insufficiently active patient. So my pond hockey players who play on Saturday and Sunday a couple weekends a month during the winter are getting benefit from that. So I've gone from kind of saying, gee, you ought to do it more regular, to saying, do whatever you can, whenever you can, and do as much of it as you can. There's also data showing that, that as your BMI increases, your lifetime risk of cardiovascular disease, and I would say other diseases that are linked to obesity, go up. That is the obesity paradox, which is talked about in some circles, isn't really true. It just happens that if you're overweight and have diabetes, you may last longer than the skinny guy with diabetes, because the skinny guy with diabetes was likely sick, and that's why the weight was low. So I think it's important to encourage your patients to keep the BMI low through physical activity to get it as low as they can within that normal range of 19 to 25. So if you look at the baseline risk for an active person versus a sedentary person, using 1 as the baseline for an inactive person, the risk is about half for an active person, whether they're 1 or 2 days a week, 3 to 4 days a week, or 5+ per week. Where the risk comes in is in that half hour to hour when they're physically active. So when you're physically active, you're clearly at more risk for heart problem or cardiovascular issue than you are when you're at rest. But during that 23 and a half or 23 hours at rest, you're at much lower risk than the person who's sedentary. So if you're using a relative risk of acute MI at 1 for a sedentary baseline, you're at 100 times more risk than the person who is very active, who has about a twofold increase above sedentary, but only while exercising. The Surgeon General's report in 1996 suggested that our biggest benefit for our patients is to get them off the couch. So if you can get somebody out of a sedentary behavior into doing anything, you make the biggest gain. So increasing my activity the same amount as a sedentary person doesn't give quite the same benefit, although as you move up the physical activity status from low to high, you gain more benefit. It's just that as you're going from no or very little activity to more activity, you have the biggest health benefits. So how do you give exercise advice? I think it's really simple to use what's called the FIT protocol: frequency, intensity, time, and type. And then I divide my exercise prescription or exercise recommendations into 3 groups: activation, which is getting the sedentary person off the couch; fitness, which is moving somebody who's somewhat active into a more active state; and competition. And I don't really do a lot of competition exercise prescription. That's what coaches are for, and that's what they get paid for, and that's what they do best. So I leave the competition to the coaches, and I work on activation and fitness in my office. And it's basically trying to get people to work at least 3 or 4 times a week, at least 30 to 60 minutes a day. I think that when you look at the time involved, somewhere in the range of 150 to 300 minutes per week, which is 300 minutes is 6 hours per week, is an optimal range for most people. But going over 300 minutes per week is fine. How hard you work, you've seen in the conference here the moderate continuous activity, high intensity interval activity, and the different ways you can move toward fitness with different timing and intensity. For type, I think that it's really important that people pick something that they like. And Victor Matsuda from Brazil, in his lectures, talks about getting people to do something they like. And if you don't like to run, you're not going to run. But if you like to dance, maybe you could go dancing daily or every other day. If you like to hike, you can get out into the countryside and do some hiking. I liked to race catamarans, and I would run most every day to stay fit enough to be on a catamaran, working hard for 3 to 6 hours during the races. I love to downhill ski, but if you're spending the time to go to the mountains to downhill ski from a flatland area like I live, you can spend a lot of money and end up in the lodge because you just don't have the strength and endurance to stay on the hill. And for fun, I inline skate. I grew up ice skating, played hockey till I was 40. New joints in the hips and knees have kind of taken away from running, but I can do things that are gliding and not pounding. So I look for people to find what they can do that they like. So I was out walking on the seashore or waterfront just now, and a bike came by, or a series of bikes came by, and a couple of them were those electric assists. And when those first came out, I thought, boy, that's cheating. And then I realized it was getting more people out. People who had gotten past an age that they felt comfortable pushing the pedals. One of my friends had a stroke. He was a superb biker, but with one bad leg, he couldn't do it. An electric assist bike, he can do it. My department chair's wife has rheumatoid arthritis. She can't push the pedals hard anymore. But with an electric assisted bike and him on his cheap bike, they can ride together and still have fun. So I look at it now, rather than cheating exercise, as extending the opportunities for people to do things. So what can you do? You're busy in the office. You don't have any time. You're running late. You just hope that your assistant took the vital signs and you can put it in your plan to talk about it next time. You got a minute. Congratulate the patient for doing well, or advise them to increase the volume a little bit more to get up to that 150. You got 2 minutes. Prepare yourself an elevator speech to talk about what you want to do for your key messages. Offer an exercise prescription. Suggest resources, pedometers, community resources, chair exercises, videos. 5 minutes, counseling. Assess their readiness for change. Look at, listen to what they like. Find what you might find, what are their barriers, what can you do together to think of things that might make them more active. And then explain how exercise can affect the diseases that are affecting their life or the risk of that disease during a lifetime. This is one of the cartoons in my local newspaper. It's called Crankshaft. I wish there was a pill you could use to stay fit. The best pill you can take is exercise. And Crankshaft replies, that's a pretty hard pill to swallow. And I think for our patients, that's what they see it as a hard routine. So exercise is the best medicine. You want to increase the activity and fitness, work toward less disease. You want to work physical activity into your work and your play. It's inexpensive medicine. It's easy to prescribe. It's hard to get adherence, and you really need to encourage your patients. And you have to remember there are some non-responders. I have patients who walk every day an hour, and they don't lose weight, and they claim to eat well, and they just don't seem to respond to exercise. So exercise improves the health and fitness of your patients. Activation improves population health. Active children become active adults, which I think is critical to remember. Physician encouragement improves the compliance, and exercise as medicine is a public health intervention that we can use, utilizing the FIT protocol and personalized personal trainers to move ahead with what I think is the big health challenge of our time. Thank you.
Bill, thank you very much. Bang on time. As this is a symposium and there will be links between the 4 talks, I think what we're going to do is press on with the next speaker, and we'll have questions for the panel at the end so we can have a thorough discussion. Thanks, Bill. Thank you. So I'd just like to introduce our next speaker, my good friend and colleague, Dr. Natasha Jones from Oxford in the UK, and she's going to be talking about the Moving Medicine Initiative, a UK perspective. Thanks, Natasha.
Thanks very much, James, and thank you all very much for being here, and thank you for inviting me to talk. It really is a great privilege. First time I've spoken outside the UK in Europe. I have spoken in other parts of the world, but it's a great privilege to be here. Thank you. My name is Natasha Jones. I'm a consultant in sport and exercise medicine. I work in Oxford in the UK at the hospitals there. I'm also Vice President of the Faculty of Sport and Exercise Medicine, and it's my great privilege to lead the team who have developed Moving Medicine over the last 2 years. Moving Medicine is part of a wider initiative which has been paid for in the UK by lottery funding. Just think about that for a minute, not by health funding, by lottery funding, and I think there's an awful lot to be said just from that one statement. It is a wide programme looking at the whole of medicine and the allied health organisations to try and improve the connect between physical activity and health, which we know is a big gap. We have a team of nearly 700 people now and literally growing daily working on Moving Medicine, and I'll tell you a little bit more about that in a minute. So what's it all about? Why have we got Moving Medicine? Why is Moving Medicine any different from exercise medicine? And what is the onward step? Because nobody wants to reinvent the wheel. Well, as we've heard very clearly in the last few minutes, exercise is the magic pill, isn't it? It's the miracle cure. We hear about this over and over again. But despite it being a magic pill and the miracle cure, very few patients hear about it from their physician, from their nurse, even from their physiotherapist. And this is the chasm that we are now faced with and that we have to address directly. So, we haven't got any sound. Just imagine a really vibrant tune underlying this. Sorry about that. Patients about exercise. Well, of course, we all know there's been an awful lot published in this area. Clinicians have told us very clearly the reason. Now, I think that's a little bit nuanced, and I come from an NHS that's been hit by austerity for the last 10 years, where time is a massive issue in a time of increasing health demand and reduced money. But I do think it is nuanced because people tend to find things for times people tend to find time for things that they think are important. You wouldn't find an orthopaedic surgeon, would you, saying he didn't think he had time to do a hip replacement. But the fact is, our clinicians feel they don't have time to do an intervention which should be just as effective as a hip replacement. The second reason that people cite for not doing this is about knowledge and skills. They say they simply don't know about it, therefore they've never been taught about it, therefore they're not going to deliver it. Well, of course, again, that is nuanced, isn't it? I think 10 years ago, when I first started out in my career, I used to give talks like this, and people used to say, "Are you sure? Does exercise really prevent cancer? Can people really feel better on chemotherapy by doing exercise? Should we really be getting people out of bed?" These are things people used to ask me regularly 10 years ago. They don't ask me this anymore. People know that exercise is a good thing, so something's happened which has changed that. When people are talking about knowledge and skills now, they're not talking about that. What they're talking about is risk. They're worried that they might do more harm than good. They're worried that if they asked people to exercise more, they might fall over, they might get lost, they might have a heart attack, they might drop down dead. These are things that do regularly get asked. The other thing that people are afraid of is another adverse outcome, and that is the possibility that they might spoil a perfectly good consultation. The patient walks out of the room with a nice little prescription for simvastatin to a consultation where the patient walks out of the room feeling judged, feeling that their doctor has subliminally accused them of being a little bit lazy, maybe being a little bit fat. And doctors have experience of that very situation. And so at the end of that consultation, they think to themselves, shall I do that? Shall I not do it? And I think a lot of people decide, and I've been guilty myself, deciding it just feels too hard. So we just leave it in the too hard box. And the third reason that people don't talk to their patients about exercise is this concern about the potential impact of that intervention. Can they really make a difference by having a conversation with a patient about exercise? Can they really change that patient's behaviour? And again, I think this is born of bitter experience of many clinicians trying to change behaviour and realising that they might have had the opposite effect. So that's what moving medicine is about. Moving medicine is there to try and start addressing some of those needs. So the first thing we did in moving medicine is produce these clinician-facing resources. And these resources have gone through an extensive process that James has been involved in of review of the literature, and then taking the literature, doing a sort of knowledge into action framework, taking the literature to the clinical context and engaging a number of experts. And when I say experts, I mean patients, carers, parents, latterly, experts in that condition, as well as clinical experts, physiotherapists, nurses, stakeholders from charitable sectors and so on. And they have put that evidence into the clinical context. And then we have delivered this evidence in sort of packages which you can look up, and you can look it up on your phone now if you like, movingmedicine.ac.uk. And you'll see that it's being put into a framework, a behavioural change framework, based on this idea of if you've got 0 minutes, you can only do this. If you've got 5 minutes, you can do this. If you've got more minutes, you can do a lot. And essentially, it's presented the evidence within a consultation framework, which is based on sound, evidence-based behaviour change theory. The second thing that we've done in moving medicine, I think, is to try and address this idea of knowledge and skills. And coming back to what I was saying earlier, that need to have a conversation which is impactful and which everybody leaves feeling good. what every doctor, every nurse wants when they finish their consultation is for the patient to walk out feeling happy, and for them to look at the patient and think, I did some good today. That patient feels better than they did when they came into the room. Now, we all know that when we talk about challenging things like behaviour, like physical activity, that can actually be quite difficult, and we can often have the opposite effect. And so these modules are very carefully designed to make sure that when you finish a consultation, if you follow the module, the patient will walk out of the room feeling better, even if you haven't changed the behaviour. Because for some patients, of course, it's not the right time in their life to change behaviour, and we have to accept that the only expert in the patient's life is the patient. We're simply there to guide them. But the fact is, unless clinicians feel good about what they do, they're not going to do it, which is one of the the tenets of moving medicine. And the third thing is, it's difficult when you're talking to clinicians of many, many years' experience to try and get them to consult in a slightly different way, to move their consultation model from sitting and listening, perhaps prescribing, to a consultation model where they actively, reflectively listen, they give affirmations, they build confidence, they build motivation. And that is a really difficult skill to learn. Now, you can learn it through looking at things like the moving medicine modules. You can learn it through other ways as well. We've just launched an 8-week online accredited, mentored learning program to teach people the skills of motivation and interviewing. I have done it myself. I think it is a really, really valuable skill to learn. And certainly some of the most experienced clinicians in Oxford have done it, people who've been doing their jobs for over 30 years and have said that it's changed their consultation completely and the way they feel about that consultation completely. So I would thoroughly recommend it. So that's the moving medicine resources. Have a look. I'm going to be talking about them in more detail tomorrow. I'm going to be talking about how they were developed and about the future developments in that. We are very happy for anybody to use these around the world. They're online, they're there. Some of it is quite UK-based. So some of the signposting at the end is quite UK-based, using UK resources. But some places around the world have asked if they can use moving medicine and then put their own local resources in at the signposting, and also change the look and feel, even change the language. Is anyone from Slovenia here today? So I'm going to try this out on you. Gibljivo zdravilo. Does that sound? Do you recognise that? No. Moving medicine. That's moving medicine in Slovenian. Yeah, there's a reason that I'm not Slovenian. Oh, doesn't it? That was a waiter in the restaurant last night who told me that. So maybe he was, yeah, okay. Right. So the second thing we're doing is to do with active hospitals. And again, we heard earlier from James, who showed us that slide, the legacy of rest slide. In the old days, of course, when people came into hospital, they often had illnesses and injuries, which meant they really did have to rest. People who came into hospital in 100 years ago often came in with infections, for example, where rest really is the best option for a short period of time. But of course, when people come into hospital these days, rest isn't the answer. And the evidence tells us that very clearly. But yet, new hospitals in the UK are still being designed with Florence Nightingale wards, where you walk in through the door and the first thing you see is a bed and a chair next to the bed. In the military, I was talking to somebody from the military yesterday, Ed, I don't know if he's here, not very well today, I think, who tells me in the military their rehabilitation wards are designed in a very different way now, so the beds are in a completely different area. And when you walk onto the ward, you see a communal area, an activity area, a social area, and then you go to bed at the end of the day rather than spending all day in bed. So what we're trying to do in the UK is change the culture in hospitals to make hospitals active hospitals, places you go to rehabilitate rather than places you go to rest. We've just completed a pilot in Oxford, which has been funded through the same lottery funding, a feasibility and acceptability pilot of an active hospital intervention, looking at how you can embed physical activity into the systems of hospitals. Because, of course, for nurses, for example, they really want the patient to be in their bed because then they know where they are. They really want the patient to be in their bed because then they know they're not going to fall over. They even want their patient to be in their bed so they can take a commode to them so they know that they've actually gone to the loo. And these are the systems that we now work with that we have to break, and it's a really, really difficult thing to do. It takes high-level leadership and changes to the way that, that hospitals function. But it's a fantastically interesting environment to be working. This has now been spread out to 2 other hospitals in the UK, or will be in the next month or 2. And we've published what we call an active hospital toolkit, which gives insight, governance, and ideas about how you can embed this into your own hospital, along with lots of resources, slide sets, teaching materials, right down to things like stair stickers. Again, I'll talk about this in much more detail tomorrow in my talk. Improbable, not impossible, I think. Sometimes it does feel impossible when you look at yet another blank face, talking about trying to get people moving more in the hospital. But it isn't impossible. We're seeing some fantastic changes in Oxford, and talking to people around the world and around our country. There's some amazing innovations going on at the moment. So that's all I wanted to say today. Please have a look at the resources. Join the moving movement. If you want to be part of this, please contact us. We're very happy to try and do everything we can to make this more accessible to you, to make this more accessible wherever you come from. We want to share experiences. We want to hear your experiences. We want to make resources which are born of experiences from all around the world. So please contact us, and thank you again very much for letting me talk today.
Thank you, Natasha. We'll take questions at the end. As I listened to the second talk now, it was clear that there's this notion of a global alliance makes it. Executive member of FIMS and from the Chinese National Institute of Sports Science, of Sports Medicine, sorry.
Thank you, Yanis, for your introduction. Good afternoon, everybody. My talk is integration. Exercise with medicine in China. This is another term regarding the exercise medicine, or just to finish the talk, moving medicine, or some people saying running medicine. This is a Chinese term. The history of the Chinese Association of the Sports Medicine will be quite long. It's over 60 years. So we can divide it 3 stages. First stage is the establishment, the purpose to join the FIMS. The second stage is 2008 for the Beijing Olympic. And last stage is a rapid development. I call it is a new era of the sports medicine. For Chinese sports medicine, we're doing 3 things. One is to give the service for the China Olympic Glory Project. I think we're doing very good so far. And the second work is give the service for Chinese National Fitness Strategy. Now we initiate the last service, the 3rd service for the health of the China street. So my talk emphasized that the 3rd one. So the concept of the integration is emphasize the concept of the comprehensive health, highlighted the role of the exercise in promoting health. The key is to implement exercise prescription. The purpose is to form the health living habit, and behavior. So we start from an initial combination, then go to deep integration. So initiation by this group from the national community, I'm one of them. So you can notice, sitting beside me is a famous athlete, Yao Ming. Yeah. We are in the same group. This group consists physicians, athletes, leaders, scientists, but they are in the top in China. So beside my many proposals for the National Committee, so I just mentioned that I do a lot of investigation for the health management in the community hospital. I also investigate the development of the scientific fitness activity regarding the young kids and older people in the different regions. I also leading many medical tours and consultations in different regions and different communities. You can notice in this group, our former films president, Kemi Chen, coming working with us. I also carry out public tour of exercise for health in the many communities. I also joined the forum, the integration of the sports and medicine for better health, is in Beijing last year. I was also on the TV for the special occasion of the National Committee meeting to talk about exercise with medicine. So I also helped the China government to sign those very important documents. The first one is published in 2014. In this particular document, mentioned exercise for all is a China national strategy. So this is a very important way and means to promote public health. And also we indicate in this document, initiate active prevention is one of the way to do it. The second document is, in this document we mentioned 435 million people will exercise regularly in China, and 300 billion people will go out for winter sports. So also indicate the implement exercise to promote health and conduct the scientific fitness guidance for the people. 2 years ago, China published a very important plan we call the National Health Program. In this document, indicate the important development, the strategy for the national health. So the government asked the deeper inclusion of the fitness and health together. So also indicate in this document, exercise prescription is a new model for health management. Also 2 years ago, government published the chronic disease prevention program. In this particular program, they asked to conduct personalized health interventions, open exercise instructor clinics in China, provide exercise health service. So I created one of the things to set up exercise prescription clinic in hospitals. So this is a new model of the integration. So put national fitness and health deeply integrated. So this kind of a clinic normally in the community hospital. The qualified physicians are responsible for exercise prescription. Qualified fitness trainers are responsible for implementing the prescription. Also, of course, the clinic also have the medical testing and physical training equipment. So first, starting in my hospital, we opened the scientific fitness clinic and exercise prescription clinic. We give a medical consultation and a physical fitness test for the normal people, civilians. We also give lectures and exercise guidance for the people. In a major hospital, I also offer the exercise prescription clinic set up. And also I often visit those already set the clinic in community hospital. Finally, I also want to mention this. This exercise with medicine also learned from ACSM. And also, of course, the training and the certificates of exercise prescription is ACM is a good function. So this is, everybody knows, I don't want to talk more about exercise prescription. What I'm doing is adopt this kind of a prescription in China, like those square dancer in the communities, so popular. Daytime, early morning in the park, evening in the empty square. Use. And for the strength training exercise progression, is getting so popular among the young people, particularly at the house club. For the flexibility exercise progression, I also encourage those Tai Chi exercise is very popular among the adults, young people. And in 2018, I visited ACM headquarters in Indianapolis. What I'm going purpose to meet those professionals, learn from them. I have achieved 5 areas to discuss. First is the certification training for the fitness professional. The second one is expansion of the exercise medicine in China. Team physician course, research, meetings, so on, 5 areas. And we signed an agreement, partnership in Minneapolis, 2018. So I was current ACS president, Walter Thompson, with me in those signing ceremony. This is a document. This document will be working for 5 years. I think it's enough for Chinese people to learn from this. So what I'm going to do is initially to have the CPT, instructor training course, in China this year. Invite 3 American experts come to give a lecture. We're doing the study, practice, and exam for those Chinese students. This is a group photo for the course 1. And over 74 students and 70 passed the exam. So I have now 70, good, in the first class. And several months ago, in August, I opened the second course. This group is much better. So almost close to 4 passed the exam. Also, I provide CPT instruction course with the American ACM support with me. Also, we signed many agreements with a training partner in China. So we will now start the certification test for the students. And this year, I also spent time to go to ACSM annual meeting in Orlando. One of my main job is to have a meeting with ACSM leaders in Orlando, this group forum, and two things were discussed. One is we gave the exercise physiologist certification in China, but the most important for physicians in China, my focus is very much focused medical doctor, physicians. I think they are the key area is for me to working on. So I talk many times with ACM. We developed this kind of certification and a training course. The purpose to training Chinese medical doctor to promote health community through education and basic exercise practice. So this is my talk. I hope this kind of integration, exercise with medicine, with whole support with the world. Whenever I go to Asia, Europe, United States, I think we're all in the same team, doing the same work. We'll be getting better and better and better health. Thank you very much.
Okay, ladies and gentlemen, I'd like you to welcome our final speaker for this session, our good friend and colleague, Dimitri Constantino from South Africa. Thank you.
Thank you very much, Chairs, and thank you to the audience for being here. And obviously, I'd like to thank the organizers for, this is running away from me, for the invitation to be part of this conference. So my discussion is going to follow in and fit quite nicely with my colleagues who presented previously. And I'm going to just give you a brief about the South African perspective in terms of exercise is medicine. So in light of what we've heard, I'm just going to give a very brief overview to start off with, looking at maybe just emphasizing the aspect of the benefits of sport and exercise to the health of nations, which was succinctly put in a couple of publications that we've seen. And this goes, this is from Lancet in 2012 in relation to sport and exercise as contributors to the health of nations. And I think, as we've heard from other speakers, we've got to that point in life that, you know, there's strong level of evidence that there is benefit. This, a little bit more recently, from 2017 in the Harvard Gazette, talking about greater health benefit from exercise than previously reported. So there's a growing body of evidence which is enhancing more and more the benefits of physical activity and exercise and physical performance and health. So, of course, we've also know and we've heard about the polypill that is the real and the only real polypill for health is exercise and physical activity. And we'll use those terms interchangeably for the benefits of this discussion. There are a number of mechanisms of how physical activity works, and of course it extends across the board. We've heard about various metabolic parameters that James spoke about, and we know that exercise in fact can work at a cellular level to impose its benefits, with a number of research coming out in terms of how general health from metabolic point of view, from a muscular point of view, and general health point of view can be influenced at a cellular level by physical activity. Of course, Yanis would be interested to know that, you know, what about the genetic aspect? And this was an interesting publication that spoke to the effect that maybe exercise could even outsmart genetics when it comes to heart disease. So we can modulate humans and health maybe more than just being a polypill, but it actually can influence genetics. And of course we know that the association of fitness, physical activity, strength and genetic risk of cardiovascular disease, which still is the leading cause of non-communicable disease, mortality and morbidity around the world. And this publication concluded that fitness and physical activity demonstrated inverse associations with incident cardiovascular disease in the general population, as well as in individuals with an elevated genetic risk for these diseases. So it's a very important thing, obviously, that we all agree to. So I'm preaching to the converted. And we know that regular exercise has benefits across the spectrum of cardiovascular disease, coronary heart disease, heart failure, stroke, diabetes, and so on. So the graphic on this slide is interesting because you'll see another logo at the bottom on the right, which is exercise right. So exercise is medicine, moving medicine, whatever term you use, exercise right is the underlying objectives are all similar for what we want to be doing for the health of our nations and for ourselves. We do know that the key health elements that can be influenced include not just cardiovascular disease, but also things like mental health with depression and dementia, breast cancer, colon cancer, various cancers, bone health, etc., diabetes. And of course, if you look at across the board, all-cause mortality can be positively influenced by physical activity in terms of how much time you spend doing that. And we won't go into the details. We've heard much about that. So exercise and chronic disease mortality, there's a definite association, and there are benefits. I would say that there's a threshold of minimal physical activity and less inactivity that one would have to do to positively influence those chronic diseases. And we know that cardiorespiratory fitness as a measure is very important in terms of mortality, not only for cardiovascular disease, which we recognize is probably the best predictor, but for a number of other conditions as well. And that is in both men and women, so there's no discrimination there. And it is also across the board in terms of age groups. So various age groups will all have benefit in relation to being fitter, so to speak. And then that age group extends not only to adults, but even in adolescents. We can see that both male and female adolescents looking at cardiorespiratory fitness can give you benefits in terms of individual risk factors. At the end of the day, it can also obviously improve longevity. So as time goes on, physical activity will lead you to have a longer life, which we know will be a better quality life when you are healthier. So we've heard about Bob Sallis, who was the brainchild behind Exercise as Medicine, and this paper specifically calls on an action on making physical activity assessment and prescription a medical standard of care. And I think we all would agree that that is the objective of what we all want to do in our own environments. So Exercise as Medicine has been adopted in South Africa by the South African Sports Medicine Association initially, and it's now expanded to become a more independent chapter, so to speak, of Exercise as Medicine. And its primary vision is to make exercise a standard preventative and treatment measure for many chronic diseases among the populations of the country. So I'm going to just tell you a little bit about what we've been doing over the last 5 years with Exercise as Medicine. So the 4 pillars of Exercise as Medicine are firstly to train and educate healthcare professionals. It's also to train and educate exercise professionals. It's to integrate the Exercise as Medicine solution into healthcare systems and to implement the EIM solution in special populations. And those are the pillars and the objectives of EIM in South Africa. So what has happened? If we start with the first organized commitments was to run an EIM track with international presenters from ACSM in particular at the South African Sports Medicine Association Congress in 2015. And at the same time at that conference, there was the launching of an online accreditation course for the exercises medicine, specifically for healthcare providers. In the same year, the course and accreditation was offered to health and fitness professionals through the Virgin Active Exercise Facilities, which is currently the largest network of gym and health centers within the country. And then an alliance was formed with two associations of healthcare professionals, one being the Biokinetics Association of South Africa. And Biokinetics, for those who don't know, are healthcare professionals involved in rehabilitation using exercise. So similar to athletic trainers, clinical physiologists, and the like. And the other group was the South African Physiotherapy Society. And to be inclusive and to promote the concept, representatives from those associations were brought onto the EIM South Africa Advisory Board. Further, in the same year, there were accreditation courses that were run at a continental rehabilitation conference. We hosted Jim Skinner in South Africa and did a kind of a roadshow with workshops promoting EIM at various universities within the country. And in that year, there were 65 healthcare professionals that were accredited and 23 health and fitness professionals. And I know those are relatively small numbers compared to my colleagues from China, but we're a lot smaller in size and population. And those are not bad figures, considering what challenges we face in this environment, which we won't go into right now. In 2016, the Biokinetics Association of South Africa hosted a conference, which it does every 2 years. This is an international conference. And again, an EIM accreditation workshop was run there. And in that year, 23 healthcare professionals and 49 health and fitness professionals were accredited. And the idea, obviously, is that these people who are accredited are going to go out and do all those things that we've discussed in terms of assessing and prescribing exercise and monitoring and so on. In 2017, the South African Sports Medicine Association Congress, which is also run every 2 years, again, a pre-conference workshop was held for EIM accreditation, and within the conference program itself, there were key EIM lectures that were presented. Again, some accreditations with 29 and 12 respectively for the healthcare professionals and the health and fitness professionals. What was something new and unique also was that we looked at and started developing an EIM accreditation course for a group of healthcare professionals which we call community health workers within the country. And these are first contact in various rural and district communities. And so we tailored the concept of EIM and started putting together an accreditation course for them to promote essentially lifestyle changes within the communities. We then also introduced continued education programs using webinars, and these are current updated topics which are presented by various people, obviously, that are trained and knowledgeable in the field. And EIM accredited professionals who've already been credentialed can then use these webinars to maintain and continue their process by being re-accredited as EIM professionals. In 2018, again, further EIM accreditation workshops were held, and we actually integrated this at my institution's academic programs with the Masters in Sports Medicine, where we integrated the exercises medicine and was part of their training and accreditation. And workshops were also held at a rehab conference which was run through the South African Physiotherapy Society. We then engaged with Discovery. Discovery is a health, well, is an insurance group with an arm being Discovery Health. It's the largest health insurer in the country, and they have what they call a Future Young Leaders program for young physicians who are still in their final stages of training and then doing their internship and community service. And we participated at that symposium and have looked at partnering with Discovery in this process of making young physicians aware and being trained in exercise medicine and the concepts of exercise and medicine. Just to give you an idea that Discovery also, we are in close discussion expanding this program. They run a program which is called Discovery Vitality, which is, in fact, has a global footprint, which is a rewards program for physical activity and healthy lifestyle. So if you eat healthily, if you exercise, and it's all obviously can be objectively measured with wearable devices and so on, and you can log in and you get points and you can get benefits from that. So the problem with this program particularly is that it's already targeting the healthy, active population. And so in the last year, I've been working hard at trying to get them to see the benefit of actually applying the rewards program to those with chronic diseases who would most benefit. And just to understand, I'm not quite sure what their reluctance is, because we all know the benefits. They have a whole floor of a beautiful building of actuaries who do all their final decision making at the end of the day. And for some reason, the actuaries don't seem to see this, the benefit, but we're getting there. Also in 2018, we presented at the ACSM meeting on an EIM solution using the concept of EIM and implementing it at a university level at my institution. And EIM has since been pretty much part of SASMA regional events. So the South African Sports Medicine Association has regional chapters, and at their meetings and through their structures, there's a presence and marketing of the brand via these events. So what we also did is in 2018 promoted EIM on campus as an initiative, as a major drive. And as I said earlier, we worked further with Discovery Health, integrating the young doctors strategy, and started training their participants in EIM. And further used the concept of train the trainers so that they would become further ambassadors of exercise medicine within the young physician group. We then, at that stage, had finalized the program and implemented the first EIM SA Community Health Worker Accreditation Workshop, where we had over 60 participants in Soweto, south of Johannesburg, and these people have been trained and certified and have gone out into communities and are actively promoting lifestyle change within those environments. We updated and developed further accreditation resource material and manuals, a lot of which have gone electronic for our courses. So we also had a look at what our colleagues have done at least in South Carolina, at the School of Medicine Greenville and the Greenville Health System, where they've very successfully incorporated exercise medicine within the medical curriculum. And this is something that we've been wanting to do, so we had a look at how they'd done it, and obviously looked at our context. With that in mind, in this year we've become the first university where I'm based as the first registered African campus on the EIM on campus initiative. And we have, in a very short space of time, with intensive negotiating, I should say, within our medical school, managed to create a thread of exercise and lifestyle medicine within the medical curriculum in the clinical years, which is 4 out of the 6 years. And through all those clinical training years, we've created a thread of lifestyle and exercises medicine concepts, and we are actively involved in that at this stage with a limited input, but from next year it's fully integrated into the curriculum, which I'm very pleased about. So also what we've done is we've redesigned the online accreditation course. It's now accessible in a better way as a modular format, where you can do any module at any point in time. You don't have to do it sequentially, and there are learning outcomes after each, and only once you've completed all the modules you could then get your accreditation. And just in terms of the program I mentioned in relation to the undergraduate medical program, we've just started, we've put together a protocol as a research project to see what the impact will be. So we've put together an approach to evaluate the knowledge and the perceptions and the beliefs of the medical students that are now in the program, and we will be integrating the EIM concept and then reassessing each year and seeing whether there is a change in the perception and the knowledge of lifestyle and exercise in medicine with these students. And in fact, yesterday, I think, yesterday or today, this morning, I'm not even sure when, we submitted the program for ethical approval for the study. And just as I leave here this week, next week we have the South African Sports Medicine Association conference in Cape Town, and we will there once again be holding an EIM workshop. So to conclude, as you can see, EIM is quite active in South Africa. We seem to be making some inroads in the awareness, education and implementation. There's still much to be done, and I think very importantly, as mentioned already, I think some form of a global alliance and collaboration and cooperation between all the movements, so to speak, would be a very good thing, and we'd support that. Thank you.
Thank you, Dimitri, and I'm not surprised at all about the importance of genetics. And as we heard from Bill Roberts' talk, I don't think they are inactivity genes, they are survival genes, because the reason is that there was an evolutionary advantage to being inactive during our evolutionary times, but that advantage now is what is killing us. But could I ask all our speakers to come up and huddle around the microphone? And while you're doing that, I would like to use the prerogative of being the chair here to ask a question, the first question, together with my friend Jürgen Steneker, who's the chair of the Exercise Medicine Europe, which is, we heard some excellent activities that are going on in your respective parts of the world. But the reality is, inactivity is a big problem and it's continuing to get worse. So could an alliance be the way forward to try and actually help the situation? Or is it a threat? So is it a threat or is it an opportunity? And I'd love to hear your views very quickly on that, then I'll open up to questions in the room. But is it a threat or an opportunity to try and improve the situation? Anyone can start.
Ladies first. Yes, I think it is an opportunity, and I shudder when people say it's a threat. I think the physical activity environment has been protectionist, to say the least, over the last, well, since I began in this 15 years ago. And I think we are a very small voice in a very big world. And so the only way to get that voice out is to combine our amazing energy and talent, put it together and work together. We all have the same message. We've heard it today many times. We now need to just work more effectively together, and so I'm delighted to be here to say that.
Fantastic.
A rose by any other name is still a rose, and our outcome is more active population for better health. What it's called doesn't really matter to me, as long as we are all working and trying to row the boat in the same direction. So from the crew analogy, if we have an 8 and we're all pulling the oar in the same direction, we're going to get there faster. If we have an 8 and we're sitting every other against each other, we're not going to go anywhere except maybe in a circle. So I think that the importance of aligning the programs is that we'll end up with a a better chance of integrating this into medical education and into the vernacular of every physician and every health provider. When I've brought it up at the University of Minnesota to go into the medical school curriculum, I'm fighting not exercise physiology, but I'm fighting neurology and biology and biochemistry and the basics sciences that don't want to give up any time, but there's already huge volumes to learn. So how can we integrate this in? And I think the ideas I've taken from today's lectures may help me do that in finding ways to put it into the clinical rotations that every medical student has to take, and not trying to just get into the basic science years. So I think there's a tremendous amount of power and opportunity here to make this a better program worldwide.
Just very quickly, I think we all agree, and I agree with the comments made, and I think that we know the biggest threat to mankind is probably not global warming, but lack of movement and inactivity, and we really need to get something done about it. So an alliance, I think, would be a great way forward.
I think it's same for China. It's a very agree with those people talk. Also, I think also have a pressure for those doctors, scientists to do precise work to fit the people or patients' needs. This is then we can see the result. Push you forward. This is my conclusion.
Thank you. Questions from the audience. Let's put them on the spot now, because it's not going to be as easy though. So microphone at the back there, and while the microphone is going to you, we should think about maybe as the alliance so we can try and influence governments so that we can actually get this in the insurance process, etc., etc. But let's put them on the spot a little bit.
So in theory, it looks very nice and works very nice, but what about practical aspects? Is there any legislation in your country supporting this type of approaching to the patients? What are the practical procedures, including exercise, into the prescription? So,
good question.
Okay, two questions.
Super,
sorry.
exactly what we wanted.
Well, in the U.S., there's no incentive for a physician to talk about exercise because we get paid for what we kill, so to speak. That is, we see somebody and do something, we get paid. If we see somebody and try to prevent disease, we really don't get paid. But until we have a more national health program or programs that will promote the discussion of exercise and the promotion of exercise, we're going to have a difficult time in the United States making this happen. In other countries, there's a better chance. I think funding from the lottery is a fabulous idea, but there's no way I'd wrest that money out of the state for exercise as medicine as a program, because as someone else mentioned, the actuaries don't see it. I mean, you can hit them over the head with all the numbers. For some reason, they can't see the benefit of exercise in medicine. So I think there's strategies out there, and I think other people have better answers than I do.
Natasha.
In the UK, I'm pleased to say our long-term plan, which has just recently been published by our current government, how long they'll last, I don't know, but we do have a long-term plan now. And it agreed in it is a prevention agenda, quite a strong prevention agenda, and there's just recently gone out a green paper on prevention, and physical activity is very much part of that, along with things like social prescribing, which is to do with prescribing not only exercise but other activities like cooking together, gardening together, and so on. So there is some movement from government now about this agenda. In terms of our National Health Service funding this in the way that they fund other health interventions, we need better data, and that's one of the reasons why we need to get together as a group. We know that exercise improves health, but what we don't know is by Dr. Bloggs talking to patient A in the consultation, does that change the patient's outcomes? It's the actual intervention. What is that actual intervention, and how can we then fund that? And that's what our NHS is searching for, which is why national programs are really important with consistent data collection.
Thank you. So in South Africa, our situation is that there's no money for basics. There's no money for food, for health, for education, for policing, security. There is definitely no money for promoting physical activity and lifestyle change. What we do have is the best that you can ever get anything written on paper. So the goodwill is there, and the government is behind lifestyle and promoting physical activity, but you and I must go out and do that. So the implementation is the biggest problem indeed. And we've got to, I think from my point of view, is we've got to start with the individuals. The individual physicians and healthcare providers must be the ones to advocate for this. And like we heard in the concussion talk this morning, you're not going to lose all your patients because you're making them healthier. There will always be patients. So we've got to do it at a mass participation level, at a very low level, to try and promote physical activity, not top down through the government.
China is a big population, and we spend over 70% of the medical care for those chronic disease. And also another figure is over 70% deaths from chronic disease. So before doctors, scientists do many things, imported the idea of exercise medicine, the effect is very slow. The title is integration of the exercise medicine. In China, exercise is another ministry controlling. Medical ministry is controlling. It's totally separate. Without a government document, cannot bring those two parts together. So my effort is to make a voice and ask government to listen, to publish this guidance document. Now you can see the community. We input exercise medicine. And it's kind of a result. The government pay the money for those doctors, give the exercise prescription, and your activity also covered by some medical insurance. It's a good start. So I think the government position is very important. Thank you.
Forgive me for stealing 2 minutes of your coffee time. You're going to know something important to say, so bear with us, please. I know we've run out of time.
The last point of go is very important. Governments think in boxes. Health insurances think in boxes. And so in a health insurance, someone is paying for medications. He doesn't want to pay less for medication because then he has less people in the insurance company. And the same for the government. We have a health ministry who is caring for hospitals, but not for prevention. And so we have to overcome these resources, these borders. And I think, what do you think, how to overcome these borders? How is it in Britain? Now you have money from the lottery. How you overcome the borders between this government, so separation, sport, exercise, and health, that is separated in most countries.
Could I ask you to keep the answers to 10 seconds each, please? Ish.
I wish I knew.
Okay.
Yeah, well, I'm pretty much on the same page. I think at the moment we're in a situation where beggars can't be choosers. We'll get our budgets from wherever we can, lottery being one of them. We've had lots of support from not only the National Health Service but also from the Department of Work and Pensions and from sport. So everybody's got their interest in this agenda. I think we can only just grow what we're doing, and eventually I do have faith that we'll come together.
Yeah, I just give you one example. The name of the change of the China Health Ministry. Before we called it Medical Ministry. Now, 1 year ago, changed the Health Ministry. We are emphasized before is diagnosis, treatment, or rehabilitation. Nobody say less prevention. Now we're talking about the health. For the patient, for the normal people. We integrate exercise as one of the elements for the medicine. So this is changing.
This is all need for a global alliance together. Exactly. I think this is very important, and I congratulate to these lectures.
Okay, ladies and gentlemen, I think it's been a fantastic session. Thank you all for staying with us and attending. I think in summary, we've all agreed that we need a global alliance. We need to be influencing governments. We need to be persuading them to help us to integrate physical activity globally into people's lifestyles. And that's going to take a huge effort, lots of policy change and lots of drivers. But it's a big initiative, and I'm sure we'll win. And enjoy your coffee break, and please thank our speakers one last time. Thank you.
Naj gre za dolgo ali kratko pot. Zdaj lahko poskrbim za svojo družino, ker moje gorivo poskrbi za moj avto. Izboljšani dodatki v gorivih MOL učinkovito zmanjšujejo obloge in tako čistijo motor. Z novo generacijo goriv MOL Evo poskrbite za motor vašega vozila. Naj gre za dolgo ali kratko pot. Zdaj lahko poskrbim za svojo družino, ker moje gorivo poskrbi za moj avto. Izboljšani dodatki v gorivih MOL učinkovito zmanjšujejo obloge in tako čistijo motor. Z novo generacijo goriv MOL Evo poskrbite za motor vašega vozila.
Exercise during training or during competition is associated with a lot of disturbance in the body, with a perturbation and alteration of the homeostasis. And the myocellular alterations, especially in myofibers, the metabolic disturbance, and the loss of body fluid justify and support the need of full recovery. Clearly, the nutrition plays a key role to restore the homeostasis after heavy exercise. But when you read the first purpose, the need of full recovery, we will discuss this point. This point is now in the focus of nutritional scientists, because we have some interesting data that support that the full recovery, especially at the metabolic recovery, is not absolutely necessary to within a training program. We will discuss this point in the first part of my proposal. I suggest we discuss the metabolic recovery and the replacement of fluid loss during exercise. The key point when we discuss about metabolic recovery concerns glucose. The glucose used during exercise is dependent of the exercise intensity. And as you show in this figure, when we increase the intensity of exercise, we increase also in parallel
the use of glucose. And for very high intensity during exercise, the presence of glucose is absolutely required. And in the body, the glucose stores as a form of glycogen are very limited. So the decrease of muscle glycogen that you show in this picture at the end of exercise and mainly in the legs needs to be replenished after exercise during the hours just after exercise. So the first question is this one: how to replenish the glycogen stores after exercise during a training program or after a competition? A lot of factors control the rate of muscle glycogen synthesis, and the first factor is this one, is the amount of carbohydrate administration. Clearly, in this figure, when we increase the carbohydrate intake, we increase the muscle glycogen synthesis rate up to a maximal value that we are shown here by this line, and this value corresponds approximately, with some variation between the subjects, but approximately to 1.2 gram of carbohydrates per kilogram of body weight and per hour. Above this value, there is no more increase of the glycogen synthesis rate. The second factor that is involved in the control of glycogen synthesis is the form of carbohydrate. And in this slide, we clearly show that 1 day after a glycogen depletion in skeletal muscle, a marked depletion of glycogen in skeletal muscle, it is when the athletes used carbohydrates with high glycemic index that the quantity of glycogen in skeletal muscle was maximum. So we can recommend now the use, and especially during the first hours after exercise, the use of carbohydrates with high glycogen index. The third factor is the timing of carbohydrate intake. And in this slide, we show with a white column the glycogen synthesis in athletes who used carbohydrate just after exercise, in comparison with athletes who used carbohydrates 2 hours after exercise. During the first part of the study, between the end of exercise and 2 hours after, there is a marked increase of glycogen when the athletes consumed carbohydrates. It's normal, but in the other athletes who don't use carbohydrates, there is no change in glycogen synthesis. And between 2 and 4 hours, what is very interesting is when athletes in the red column consumed carbohydrates just at 2 hours, there is no major increase of glycogen synthesis. And when we add the white column and the red column, clearly it is when athletes consumed carbohydrates just at the end of exercise that the muscle glycogen was maximum. So now it's clear, glycogen synthesis needs to consume carbohydrate just at the end of exercise. And what are the quantities that are recommended in such a condition? We recommend between 60 to 80 grams within the first 30 minutes, just after exercise, and thereafter the quantities that are recommended are here reported in this slide. And what is very important, the major point of the recommendation now, is
to recommend such intake of carbohydrate just at the end of exercise. That is a very important point. Very important point if one objective of recovery is to quickly replenish muscle glycogen. Muscle glycogen and, of course, liver glycogen, but we cannot measure directly liver glycogen. Another point is very important to optimize and maximize the glycogen synthesis rate is maybe the addition of a quantity of protein together with carbohydrates and especially glucose. In this study, that is one of the first studies that address this issue, the authors compared the similar quantities of energy under the form of glucose plus or not proteins. And they showed that when a quantity of protein, here 28 grams of protein, was combined with 80 grams of carbohydrates, of glucose, there was a maximal glycogen synthesis rate in comparison with the same quantity of energy, but under only the form of glucose, 108 grams of glucose. So this study is at the origin of such recommendation, the combination, the addition of small quantities of protein with glucose in order to increase the glycogen synthesis rate. That is, this recommendation is verified, but only until some quantity of carbohydrate ingestion rate. If this recommendation is valid and can be confirmed only if the athlete has the possibility to consume small or limited quantities of carbohydrates. You show in this slide the increased quantity of carbohydrates intakes, and here the muscle glycogen synthetic rate. And we compare here this line that corresponds only to carbohydrates, and this line with a combination of carbohydrates and protein. And you show that up to this value, 1.2 and 1.4 gram per kilogram body weight per hour, after this value, there is no difference between these two strategies of nutrition. So the addition of small quantities of protein is such confirmed, but only when athletes is able to consume limited quantities of carbohydrate. Another point is also interesting, is the recommendation of two different carbohydrates, mostly glucose and fructose, to increase the availability of carbohydrates in the body, especially glucose, to optimize the glycogen synthesis rate. As you know, the absorption of glucose in the body is dependent of the presence of one specific transporter in the blood, the SGLT1 here. But the maximal quantity of absorption, glucose absorption, is limited in the body, and above a specific value of carbohydrate intake, the glucose is not absorbed in the body and is not available in the blood. That is why one hypothesis was to add another carbohydrate, fructose, that use another specific transporter, GLUT5, here in the gut. And when we add glucose and fructose, we can increase the availability of glucose in the body because the fructose available in the blood will be converted in glucose in the liver, and the availability of glucose at the end is improved. And that is an interesting strategy, but only if fast glycogen recovery is needed. This recommendation is not variable, is not confirmed by experimental data if we don't need to optimize, to maximize the speed of glycogen synthesis in skeletal muscle. One interesting question also was the best ratio between glucose and fructose, and in most experiments we use 2 parts of glucose for 1 part of fructose. So we have seen some data concerning how to replenish the glycogen stores. But now this question also is very interesting. Is it always necessary to replenish glycogen stores? And during training, and of course only during training with low muscle glycogen availability could be an interesting way to amplify, to optimize the response to endurance exercise. Only endurance exercise. And in this experiment, for example, after 3 weeks, it is an experimental design only, of course, because there are some limiting factors, but in this experiment, after 3 weeks of training with low glycogen availability, you show here a major increase of the citrate synthase activity in skeletal muscle. The citrate synthase activity in skeletal muscle is representative of the oxygen capacity in muscle and the capacity of muscle to oxidize substrates like fatty acids and like glucose. And the response to training in subjects who were subjected to this type of training, the low glycogen training, you show here the marked increase of citrate synthase activity in comparison with subjects who were submitted to this training with an optimal glycogen stores. And that is very interesting, and it's clearly now explained by the muscle biology. Because when we decrease the glycogen stores in the myofibers, and if myofibers are activated during contraction, there is an increase of these 2 key enzymes in myofibers, AMP kinase and the P38 kinase. And this kinase, these enzymes, activate PGC1 alpha. PGC1 alpha is the key regulator of the expression of the nuclear genome for mitochondria and the mitochondrial genome. And there is clearly a major response of the mitochondria during this type of endurance training if sometime the athletes are trained with low glycogen availability in skeletal muscles. So that is very interesting, but some specific point needs absolutely to be highlighted. Training low, for example, should be undertaken during moderate workload sessions, only moderate workload session. And during this session, athletes will benefit for the individual tolerance from the carbohydrates mouse rise during exercise. And what is also very, very important during this phase, this type of training, is to preserve the protein intake, because as we will show thereafter, protein intake is absolutely necessary to preserve the response to training. And training low glycogen availability, training low sessions must be a minority of the training session and integrated into a general program, including session with high carbohydrate availability, of course. So, to summarize what concerns the muscle glycogen recovery, if we need a fast glycogen recovery, we can recommend such carbohydrate intake and a mix of carbohydrate with a mix of glucose with fructose, with 2 parts and 1 part of each of these carbohydrates. For whole absolute carbohydrate with high to moderate glycemic index, as we have shown, and training low can be clearly an interesting method, but to program with great caution. The second point is the free dose replacement. The free dose replacement depends, of course, strictly from the extent of fluid loss. The extent of fluid loss is dependent from the hot environment, of course, the hot climate. It's dependent also on the intensity of exercise. But another point also that is very important is the inter-individual variability in the sweat rate. And when we look at this figure, we show that in the same environment, with the same ambient temperature, with the same humidity, and when subjects are submitted to the same exercise with the same workload, you show here a great variation of the sweat rate and, of course, of the fluid loss during such condition. And if you look here at the values, you can show that the sweat rate can vary by a factor 3 between the more economic athlete to the less economic athlete, with here fluid losses that are approximately to 2 liters per hour. This great inter-individual variability of the sweat rate and, of course, of the fluid losses is determinant for the fluid loss recovery after exercise. And this individual variability is sometimes very difficult to take into account and to manage, but that is a very important point. And everybody thinks at the ambient condition, at the intensity of the exercise, but maybe one of the main determinant factor is this individual variability. So now, how we can obtain an optimal recovery of the fluid losses during exercise? There are mainly 3 points. The first one is to contribute to the voluntary fluid intake. To stimulate the voluntary fluid intake, we can act and play with 2 factors. The first one is the temperature of the beverage. And as you show in this meta-analysis here, clearly the cool beverage are more consumed and are consumed with a higher volume than the beverage that are at ambient temperature. The temperature of the beverage is very important to stimulate the spontaneous consumption of beverage. The second factor is the flavor. And when we look at this meta-analysis, we clearly show also that the beverage with a specific flavor are more consumed with higher volumes than plain water or water without flavor. So, cool beverage with flavor are more spontaneously more consumed than the other beverage. And that is the first point. And when we look what happened in the field, it's very rare when we have the availability, the full availability of cool beverage with flavor. It's very rare. Or this point is very important to stimulate the spontaneous consumption of beverage. The second point is to recommend drinks that do not use as a carbohydrate vector, and we combine mostly fluids with carbohydrate. But the osmolality of the beverage and the quantity of carbohydrates in the beverage could be a negative factor for the gastric emptying. And if we have more than 70 to 80 grams per liter in the beverage, clearly the gastric emptying is affected, is altered. That is why mainly when the objective of rehydration is to promote the availability of water, we recommend beverage with low quantities of carbohydrates, no more than 30 to 40 grams per liter, in order to favor the gastric emptying and the absorption of fluid in the gut and its availability in the body. The third point is the presence of sodium chloride. A small quantity of sodium is absolutely mandatory if we need to maximize, optimize the fluid intake in the gut. And the volume. What volume is recommended during recovery at the end of exercise, during training, approximately to 140 to 150% of the post-exercise deficit in fluid. And for each kilogram that has been lost during exercise, we recommend approximately 1.4 to 1.5 liters. The fluid consumption also has to be over time and rather than ingested in larger volumes, because larger volumes of fluid intake are at the origin of gastrointestinal disturbances, and these disturbances clearly are at the origin of a decrease of fluid intake and are at the end, at the origin of a fluid deficit. So, to summarize this point, the effective rehydration requires the intake of greater volumes than the fluid deficit measured beverage. This point, once again, is very important. The fast recovery of fluid loss could be necessary if the dehydration is important, substantial, more than 5%, or if rehydration is needed within 24 hours or during one day. In this case, beverage have to be consumed also early after exercise with a specific hydration plan. And in this case, with major dehydration, it will be very important to suggest and to recommend beverage with low quantities of carbohydrates, no more than 30 to 40 grams per liter. So the third point that is very important for recovery is the myocellular recovery. The myocellular recovery is mainly supported by these 2 points: the repair of contraction-induced myocellular damage, mainly when exercise comprise eccentric contractions, markedly decreased during exercise. So when we look at the balance between protein synthesis and protein degradation during exercise and just after exercise, it's similar for all these types of exercise. There is a marked decrease of protein synthesis the end of exercise, there is a marked increase of protein synthesis. And this time, this period is a critical period to improve the amino acid availability because, of course, protein synthesis is dependent of the availability of amino acids and essential amino acids. So that is an hypothesis that is confirmed at the experimental point of view, but when we look and when we show this marked increase of protein synthesis, clearly we are in a period in which the availability of amino acid is critical. So the appropriate protein intake is an important component of recovery, and this, once again, what is very important for all sports and all disciplines. Strength athletes are very focused on the necessity, the requirement of protein intake, not endurance athlete. But protein requirement and the amino acid availability is absolutely necessary for all these sports and disciplines. But what kind of protein? Fast or slow proteins? As you know, there are mainly two categories of protein. Protein for which the availability of amino acids in the body is very fast, very quick, and slow protein with which the availability is delayed during the time. And these two types of protein are characterized by the whey protein. So whey protein is the typical fast protein, and casein is the typical slow protein. And when we compare the changes of muscle protein synthesis after the consumption of whey proteins, caseins, or soy proteins, the main vegetable protein, when we compare the changes in muscle protein synthesis at the end of exercise for similar quantities of proteins that have been consumed, we clearly show that it is with fast protein that we obtain the maximal changes, the maximal increase in muscle protein synthesis. So in this situation, the first step, we can recommend fast protein just after exercise. What is the best timing of protein ingestion, of protein intake? In this experiment, the author tested this hypothesis, this issue, and they compare the early consumption of 10 grams of protein at the end of exercise, and they compare this situation with a late consumption of proteins, the same quantity of proteins, 10 grams, but 2 hours after the end of exercise. And here, in this part of the histogram, you have the balance between protein synthesis and protein degradation and protein breakdown. And the only situation in which the muscle, the skeletal muscle, is in an anabolic status when protein synthesis is higher than protein breakdown, is this situation is when protein has been consumed just at the end of exercise. That is why now, and this recommendation is very similar to carbohydrate intake, we recommend now the consumption of proteins early after the end exercise, within the 13 minutes after the end of exercise. What optimal quantity of protein we can recommend for these athletes? And we have now good data that has been done at the end of exercise and dependent on the body weight and dependent also of the muscle mass And we clearly show here in this histogram that when we increase the quantity of protein consumed at the end of exercise, we increase here the myofibrillar protein synthesis in skeletal muscles, of course, until a quantity here in which we don't observe any major increase of protein synthesis. And this point here corresponds approximately to 0.24-25 grams of protein per kilogram of body weight. And this corresponds, of course, according to the body weight, to 20 to 25 grams of proteins at the end of exercise, and mainly fast protein just at the end of exercise. So, increasing the muscle protein synthesis during recovery should be viewed as an important nutritional strategy. Now this strategy is very confirmed and is diffused, and we have now a good knowledge of the main recommendation for this myocellular recovery after exercise. And once again, this is very important for both endurance athletes and resistance trained athletes. For endurance athletes, what is important is to repair the myofibrillar damage during exercise, during eccentric contraction during exercise, and to optimize here the remodeling of skeletal muscle and the increase of the mitochondrial network within skeletal muscle. And for resistance athletes, what is important is to optimize the protein synthesis at the end of exercise. What is very important now, also, is to consider that this protein intake has to be recommended at the end of exercise, immediately after exercise, with these optimal quantities of protein, 20 to 25 grams approximately. And another question that is not clearly solved today is the optimal ratio between fast and slow proteins that we can recommend, not just at the end of exercise, but during the few hours after exercise. And we have done recently an experiment to address this issue that has been published recently, and we don't see any optimal ratio between fast and slow protein to optimize the muscle recovery. That is, this question is open for further experiments. And also what is very important for athletes is that protein must absolutely be mainly provided by foodstuffs and not only by protein powder. Because foodstuffs are also associated with another macronutrients and a lot of micronutrients that are essential for the recovery. And we have several categories of proteins that are available in foodstuffs, of course, but we have also to choose this food according to the variation of the amino acid content, and especially the content of essential amino acids. So what is now, to finish this talk, what is now the role played by the dietary supplements? To address this question, a lot of time is necessary, of course, and I will focus only my talk on, and only with a few slides, on one type of these dietary supplements that is now in the focus of many athletes, mainly in cycling. It is the ketones. Clearly, the ketones benefits now from a good publicity during in athletes and in cycling especially, and you have here a lot of pictures from the web And you show here a riders, of course, a rider with a helmet and so on. This dietary supplement is very intriguing. And we have now a lot of data that can be very important to know, to have a good opinion of the possibility and the effects of ketones to improve performance and, in this topic, to recover after exercise. But what are ketones? Ketones are mainly these two substances, beta-hydroxybutyrate and acetoacetate, and with circulating fatty acids, and ketones are produced in the body naturally and according to the availability of carbohydrates. And what is very interesting is that ketones provide a good alternative to glucose for the brain, for skeletal muscle, that is important for exercise, and cardiac metabolism. And considering this point, and because ketones elevates insulin and preserve the glucose oxidation, one hypothesis has been that ketones will be able to improve the glycogen repletion during recovery after exhaustive exercise. That was the hypothesis at the origin of 3 experiments, no more. To date, we have only 3 experiments to address this issue. The first experiment is this one, in which the voluntary subjects took 3 types of beverage at the end of exercise, a placebo beverage, glucose, and glucose plus ketones. And the authors measured the glycogen synthesis rate in skeletal muscle at the end of exercise and during the hours after after the beverage consumption. And what is interesting in this experiment that has been done in laboratory is the quantity of glucose that has been taken to the subject has been done by a clamp, a glucose clamp, but a glucose clamp with a value of glycemia of 10 nanomoles. 10 nanomoles is a very high quantity of glucose, and in this experiment, the availability of glucose was very high. And they showed that when the subjects consumed glucose plus ketone, there was a higher synthetic rate of glycogen than when subjects consumed only glucose with this glycemic clamp. So this was the first experiment published in 17, but with an experimental design that can be done only in laboratories. This experiment has been published a few months after, the same year, and in this experiment that was closer to the field.
Okay, so stand up. You will finish later. Okay, it's time for the last energy shot. Come on. I know you're feeling tired. I'm as well. Forward, right.
Naj gre za dolgo ali kratko pot. Zdaj lahko poskrbim za svojo družino, ker moje gorivo poskrbi za moj avto. Izboljšani dodatki v gorivih MOL učinkovito zmanjšujejo obloge in tako čistijo motor. Z novo generacijo goriv MOL Evo poskrbite za motor vašega vozila. Naj gre za dolgo ali kratko pot. Zdaj lahko poskrbim za svojo družino, ker moje gorivo poskrbi za moj avto. Izboljšani dodatki v gorivih MOL učinkovito zmanjšujejo obloge in tako čistijo motor. Z novo generacijo goriv MOL Evo poskrbi.
So I have the questions. We in the sport training quite often use the term supercompensation. And normally the supercompensation is something like if you perform one kind of training, it should be rebuilt in a certain period of time, even better performance. But behind this is nothing else like replenishment of the protein. Because if we do some activities over 85% of the intensity, mostly in the speed power sports, we destroy the cells. And the cells are built from the protein, so we have to rebuild them. So my question is, if we apply replenishment right away after the training or exercise, can we also accelerate the process of supercompensation? The process of supercompensation has to take its own time. That means the body has to rebuild what lost during the training by themselves.
Yes, thank you for this very interesting question. But supercompensation is mainly scheduled before competition. I address here the issues of the recovery from exhaustive exercise during training or competition. And surcompensation of muscle glycogen is possible during the three days before an exhaustive competition for endurance athlete, for example. But only by the way of the decrease of carbohydrate availability during the dietary normal habitudes, not at the end of exercise training, because during this period, the training sessions are very light and the intensity of the training session are very low. And we can obtain a surcompensation of muscle glycogen by the decrease of glycogen, of carbohydrate in the normal diet, followed by an increase of the carbohydrate in the diet. But only in the diet, it's not at the end of exercise session. That is why I don't address this issue during my talk.
Okay, thank you. I have several questions, but I'll start with the fact that I didn't see in your presentation the relationship to the leucine content of those specific formula that you've used, because this is one of the stronger triggers to create that. This is the first question, because it may be related to the trigger of the muscle protein synthesis. The other one is, we all think about how to push it. We try to be very technological, when to do it and how quickly we can do it. But the fact is that the best time for protein synthesis is at night when you sleep. So either it's a position that maybe after exercise you should try and put them in a laying position to see if that increase the speed, or because there are mechanical triggers that may affect in the nutritional part. So there are so many factors around it. But I'll start with the leucine, go with that. And I was surprised to see that you used 10 grams in one of your drinking. The use, although you're talking about 20 to 25 that you're supposed to do. So this is not an optimal dose for that specific study. I was wondering if you think that the timing, although we try to push it after the exercise, because that's what everybody wants. You go to eat immediately, you take a drink after that. Maybe you should go eat a good dinner, a good lunch, and go to lay down, as you're going to protein synthesis will be a lot better than anything else.
Yes, you are right, but this quantity of protein that is recommended just at the end of exercise is just after the shower. It's a very fast and very quick recovery. 20 to 25 grams are recommended in this condition. But thereafter, 2 hours after, 3 hours after, a meal is able also to provide the complement of proteins, of course. It's normal. One interesting point you address also is now some recommendation of protein intake just before the sleep. And this is very interesting. 2 papers have been published some years ago in which the author showed that when exercise is scheduled at the end of the day, and if the subject consumes 20 grams of fast protein just after exercise, took a short meal after, and 40 grams of casein, slow proteins, 40 grams of protein just before the sleep, there was an increase of the muscle mass gain during the 3 weeks of training. This experiment was very interesting, but the question was why the gain of muscle mass was increased, was improved by the slow proteins. Is why slow proteins are consumed just before the sleep to improve the amino acid availability during the night, or because these slow proteins are consumed after fast protein, after exercise. And we have done just an experiment. This experiment has been finished during the year. The paper is not submitted now. And we have shown that when we organize differently the schedule during the day with an exercise in the morning, the fast protein, slow protein 2 hours, 3 hours after the end of exercise, or in another design, the exercise during the day, during the morning, fast protein, and slow protein just before the sleep. The best situation was the first one. When we combine first fast protein, thereafter slow proteins. So we are not sure today that slow protein just before the sleep are able to improve the gain or stabilize the muscle mass. This point is very important because one recommendation, one indication of such schedule could be in elderly people, in which it could be very important to preserve muscle mass and to improve the availability of amino acid during the night. But it's not clear. The results now are not clear.
You control for the leucine content in your supplement?
The
leucine content?
Yes, of course. Yes,
so
yes.
At least 2 grams in any one of those doses. Okay.
Yeah. The content of all amino acids were controlled and the proteins were similar.
Do you have a leucine equivalent in each one of those tests that you did for the...
Yes, we have tested. Yes, of course.
This is now the last question. We are far over the time, yeah.
Because normally we train, major training is afternoon, and we actually finish this training about 6 p.m. You show us that earlier delivery of supplements, 0 to 2 hours, or second period, 2 to 4. If we take the 4 hours and we finish the training 6 p.m., 4 hours is exactly 10 p.m. So we go to bed around 10:30. So this is exactly, the period that we make intake and we go to the sleep and we see what happened in the process in our body.
Yes, it's a good comment. But don't forget that these situations are experimental design. These are experiments in order to confirm or to delete the hypothesis. These situations are only models. They are not applied for athletes during training. it's only models to verify the hypothesis.
Exactly.
Thank you for this comment.
Thank you.
Thank you again, Professor, for this nice discussion and also to public.
Thank you to you for your presence. Thank you.
Now we have to move on. I would like to announce Frank Moran, Professor Frank Moran from Germany. He's going to speak about prevention of gastrointestinal problems in marathon runners. Or body composition monitoring is part of clinical nutrition assessment, is special field. So we are doing this for many years. I tried to summarize guidelines, but there in fact are not many. We have a very promising paper from '96, but then it was not many more published, so I tried to get some useful information from IOC recommendation, LLL model on body composition measurements during nutritional assessment. LLL models are models during long life learning, nutritional models from ESPEN. And we also have ESPEN guidelines for bioimpedance measurements, part 1 and part 2, which are still, I would say, gold standard, are pretty old now with current knowledge and current experiences, so I think must be updated. So I will try to summarize something based on this. With bioimpedance, I will speak just about bioimpedance. We get some biological signal because we are kind of biological electric body, and if we put some alternating current inside then we can get signal. These currents have different frequencies. You can see 5 hertz, 200 hertz, and so much. So more currents we use, more complex signal we get. So we have really different machines, different methods inside of this field. So it's really difficult to compare different measurements with bioimpedance. And this is a great or a big obstacle in this field, how to compare biological signals which we get from different methods. As I said, we are using bioimpedance as a method how to evaluate body composition during nutritional assessment, and when we work with sportsmen also we evaluate performance in the same time. So in children we can refer that this is really important in the last line when we evaluate changes in growth, and we have risk groups, young athletes, which are quite prone to different metabolic disturbances because of, I would say, too much training, inappropriate nutrition. And also many young athletes are too early included in strict regime in weight-sensitive sports, and this is another issue. I will fly over these body compartments. We really don't have time, but we have to be aware that when we measure, for example, body mass index, this is more or less population-based measurement, not individual. If we want to measure body mass of an individual, we have to measure composition, always with a method which we have. Now we are speaking about bioimpedance. With bioimpedance, we get signal from these basic molecular compartments. We just have to know physiology or part of physiology behind this regarding metabolic status of individual. We have to be aware that this is very dynamic body mass structure. These are very dynamic body mass structure changes during aging. You can see here are not children, but children have even more water. So when children grow, water is decreasing, and so apparently they are getting fat and lean mass. And this is also signal from UpToDate, which I just copied. And also UpToDate, you know, this is medical platform with new informations, make a place for using bioimpedance in children. And when we are using bioimpedance as a reflection of signals, we have to know that this body composition measurements reflects also weight loss, undernutrition, and also growth. This is biological basis. But what is much more important, if we are using this in clinical setting, when we are also evaluating performance, we can also see how much we have metabolic load, how much we have metabolic capacity in individual, and we can translate this in nutritional strategies, recovery strategies, and also training adaptation. In everyday practice, we are using this a lot. For example, when we are monitoring children during adolescence, because each coach wants that the children don't get fat. You know, this is a major obstacle which we see. So, and we can diminish, I would say, nutritional dieting, which can damage young athletes with this monitoring. But we have to be aware always that what we would like to have, the most functional in athletes, is body cell mass, which is main element of function. And when there is less intake or uptake of food, you have just seen that during training, gut function is not working very well. This then body cell mass goes down. And also inflammatory activity, which is also related with physical activity, because physical activity causes inflammation. But we have to know when this situation is acute, chronic, subacute, so we really have to understand a relation between body cell mass and extracellular mass, because here is also water. And this method, bioimpedance, is based on ions, ion current in water. So when we speak about normal body composition, this is in children. I will refer to children when we have stable body cell mass, and so we can monitor actively metabolizing part of the body, and don't lose this, because children need this not just for athletic activity, but also for growth and maturation of the body. Body composition measurement is whole body method, bedside method. Other methods I will not comment now, we don't have time. Usually we use kind of machine, which can be like this one, and at this machine people are lying, but now it's a bunch of machines which are also with standing position. I will discuss this also. We calculate compartments with determination of total body water, then fat-free mass is calculated, and there is an equation behind which estimates body cell mass and fat mass. There are, of course, situations when we cannot use this properly, but we have to know how to put this. But I would like to put into discussion this. If we look how to measure body composition, the basic recommendation is to measure it supine, because we are speaking about current flow through water. So if we measure it in standing position, then we have to take in account gravitation. And if we look at recommendation, body position supine is recommended, because also majority of equations are made in this, are formed in this position. There is quite tricky recommendation in these 2004 guidelines that except for scale type BR instruments, I don't understand this very well, but of course, if we would like to follow standard quickly, not quickly, but exactly we have to measure body composition in supine position, then the probability to get more exact results is much higher. The next thing, which we use a lot in medicine, is face angle. I again don't have time to go through this, so I will just refer that face angle gives us function of the membrane, and it correlates with cellular health. And if we have an adolescent, and then we see how face angle is going up, down, and then we do nutritional assessment, then we assess his training and so on, then we can see how his all these influence his face angle, and this, I must say, is maybe the bigger help to evaluate nutritional status, performance, and performance of adolescent athletes. So if I summarize, bioimpedance measurement is a method for measuring, according to guidelines, total body water. We can get fat-free mass through equations, but just we have to know limitations. We can get indication about total body cell mass or whole body protein. Again, we have to know what is pathophysiology or physiology behind this. So in young athletes, we can quite well measure nutritional status. We can quite well measure hydration if we know the situation. And what I found the most important is their function during their growth period. But what is the most important is that we always have to individualize body composition, and goals of this must be determined before with coaches, with the athlete, which kind of body composition the athlete would like to have and how we will follow this. We have a practice, but I don't go now in this because we really don't have time. We found also quite well correlations with Rett syndrome. We are doing now one big analysis when we have lower intracellular volume. Just if I say like that, then cells are not as big as they could be if we have low energy availability. We expect much bigger influence on this when we will analyze all 100 young athletes which we have, but so far even on 20 athletes we found this indication. And if we watch at one very practical measurement, you can see here we have female, 18 years old, with Rett syndrome already diagnosed. What we can see? We can see quite low face angle if she's athlete. This is like face angle for normal 18 years old girl, not face angle for athlete. And we have very low fat-free mass index. If we look at criteria, this is already sarcopenia. And what is also important, she's 18 years old, she should be mature, but she still have very high amount of total body water. And we know when you are starving, when you have, in this case, low energy availability because she has a Rett syndrome, then she has, overload of water. So her real weight, her functional weight is even lower. So when we are making nutritional strategy for this patient, our goal is to lower body water because after face angle will recover and also her body composition. Yes? Yeah, sure. But this is 66, yeah, but it's too high, really too high to this age.
5 of it is intravascular blood.
No, it's not. Because if you look at the group, this is much higher than it should be in this group. this is probably starving water because she's exercising, she's in stress metabolism, she's full of cortisol probably, because she needs energy. So we think here is stress starvation when you accumulate stress water, and when we make strategies
I understand, but the free fat mass, including the hydration in the cell,
it should be
and intravascular, because there's not.
But I think here is even lower value in real because we have so high water.
No, it's lower, I agree. But the difference between 14 to 8 is 6 kilos, what I'm saying. So 5 of it.
But this parameter we really never use. I don't understand very well this parameter.
I calculate the difference.
We never take this into account because I cannot find this useful. So we go for face angle, we go for water compartments, and we try to use this because this is validated calculation. We use this. And this was the last slide. I hope I was fast enough not to steal too much of your time because today is dinner. Use BIA. I found it very useful for different purposes, but you must know what is backup of this BIA. Clinical situation, training situation, and then data can be valuable. You have to individualize it, and longitudinal use in individuals, it can give you really valuable information in the sense of health and in the sense of performance. Thank you.
Naj gre za dolgo ali kratko pot. Zdaj lahko poskrbim za svojo družino, ker moje gorivo poskrbi za moj avto. Izboljšani dodatki v gorivih MOL učinkovito zmanjšujejo obloge in tako čistijo motor. Z novo generacijo goriv MOL Evo poskrbite za motor vašega vozila.